Hello everyone, this is Dr. Govind Rai Garg. In this video, we will discuss a very important topic which is not only important from ANS point of view, but that will help us to understand a lot about cardiovascular system and a little bit about central nervous system also. Okay? And the topic is adrenergic drugs or sympathetic system. So what we will expect you to remember from this chapter. So first of all, we'll discuss about the various receptors of adrenergic system. Then two type of adrenergic drugs we will divide: indirectly acting and directly acting. Indirectly acting drugs include reuptake inhibitors and drugs acting by displacement, whereas directly acting drugs will be catecholamines and non-catecholamines. And one very important phenomenon we will discuss, that is vasomotor reversal of Dale. Okay, so all these things we will cover in this chapter. So we will start with the basics of sympathetic system, quickly revising what we already know. So what we already know about sympathetic system, let me know quickly. Sympathetic system originate from? Yes, it originates from thoracolumbar system. Thoracic and lumbar portion of spinal cord. They form a connection in the ganglion, which is near the spinal cord. So preganglionic fibers are shorter and postganglionic are longer. And neurotransmitter in the ganglion, like everywhere, is acetylcholine, but neurotransmitter in the organs is, yes, it is noradrenaline. Mostly it is noradrenaline, but at one exception we discussed is in the sweat glands, the neurotransmitter is acetylcholine. Okay, and the functions we also discussed. Functions are: sympathetic system stimulate the heart, it increase heart rate, increase conduction, increase contractility, but it inhibit most other things. Okay, that we already discussed. Now we will start here with the major neurotransmitter, that is noradrenaline. So first we'll try to understand from where it comes, where it goes, what it does, and then we can discuss the drugs acting on sympathetic system. Okay, if you see, this is first neuron, this is second neuron. First neuron, we know it is storing the noradrenaline. The question is from where this noradrenaline comes. We discuss the same question in the parasympathetic system also. The answer is also same. Noradrenaline is produced by this neuron. Remember, it is a neurotransmitter, so it has to be synthesized in the neuron. But for synthesis, we can take raw material from outside. And what is the raw material here? Yes, it is tyrosine. So the first step is tyrosine is taken from outside. Tyrosine is converted to dopa. Actually, if you see the tyrosine, it is in outside the neuron. Tyrosine is formed from phenylalanine. Phenylalanine is an amino acid. It is converted to tyrosine. The enzyme is phenylalanine hydroxylase. So you can say that tyrosine is monohydroxyphenylalanine. Okay. Now tyrosine is converted to dopa. The enzyme is tyrosine hydroxylase. That means it is hydroxylated again. So it becomes dihydroxyphenylalanine. So the full form of dopa is dihydroxyphenylalanine. Okay. So tyrosine comes from outside and it is converted to dopa. Now this dopa is converted to dopamine. Dopamine I write as DA, but it is dopamine. Now this dopamine, it will quickly go inside the vesicle and is converted to noradrenaline. Okay. Now if you want to discuss a little detail, this dopamine is converted to noradrenaline if an enzyme is present which is known as dopamine beta hydroxylase. So some neurons have that enzyme dopamine beta hydroxylase. They can convert dopamine to noradrenaline. If that neuron is not present, as is the case in some neurons in the brain, the end product is dopamine. So those neurons contain dopamine as a neurotransmitter. But some neurons have one further enzyme which can convert noradrenaline to adrenaline. That is known as methyltransferase enzyme. So that convert noradrenaline to adrenaline, and in the adrenal medulla that enzyme is also present. So the end product is adrenaline. So what will be the end product as a neurotransmitter in which neuron? That will depend upon the number of enzymes present. If dopamine beta hydroxylase is present, the end product will be noradrenaline. If that is not present, it will be dopamine. And if methyltransferase enzyme is also present, then the end product will be adrenaline. So different neurons may have different end products. In sympathetic system, end product is noradrenaline at most places. Okay, so noradrenaline is produced and stored whenever nerve impulse comes. noradrenaline is released, exocytosis occur. Now this noradrenaline will work on the receptors. Whichever receptors are present, they will be stimulated. Now we know that no substance keep on working forever. So we have to stop the action also. So noradrenaline action is mainly terminated by reuptake. Noradrenaline go back into the vesicle. This is known as reuptake, which is the main mechanism of termination of action. Okay? So there are minor mechanisms also, like it can be taken up by the postsynaptic neuron also, and it can be metabolized by monoamine oxidase also. There are other methods also, but the most important one is reuptake. Okay. So quickly revising what we have discussed, tyrosine comes from outside. It is converted to dopa. Dopa is converted to dopamine. Dopamine enter the vesicle and it is converted to noradrenaline. Whenever nerve impulse come, noradrenaline is secreted. It will work and then it is reuptaken and the action stops. Okay. Now, can you see that the system is very similar to parasympathetic system, acetylcholine, if you remember? In that also, first something come from outside inside the neuron, like choline comes in that case. Then that is converted to neurotransmitter, that is acetylcholine. That will be released, work on the receptors, and then the action is terminated. The same thing here. So some substance enter from outside, forms the neurotransmitter, which is stored in the vesicle. Whenever nerve impulse comes, neurotransmitter is secreted, it works, and then the action is terminated. The same thing here. But the differences are very clear from the parasympathetic system. What are the clear differences you can note? Yes, number one, the number of steps are too many. In parasympathetic system, there was only one step, that is choline is converted to acetylcholine. But here there are 3-4 steps. Tyrosine is converted to dopa, dopa to dopamine, dopamine to noradrenaline. So many steps are there. Second major difference, method of termination is different. Acetylcholine action is terminated by metabolism. Acetylcholine esterase metabolize it. Whereas noradrenaline action is terminated by reuptake. It go back into the vesicle. Okay? And the third main difference between the sympathetic and parasympathetic system here is the rate limiting step. What was the rate limiting step in parasympathetic system? Yes, that was uptake of choline. But here the rate limiting enzyme is tyrosine hydroxylase. So rate limiting step is conversion of tyrosine to dopa. So rate limiting step is conversion of tyrosine to dopa, or we can say rate limiting enzyme is tyrosine hydroxylase. Okay. Otherwise, the system is quite similar. The basic things are same, slight differences are there. And just like parasympathetic system we discussed, if noradrenaline is present here, it is working. So if we give a drug that increase or decrease noradrenaline in the synapse, then the action will change. If a drug decrease noradrenaline, it will decrease sympathetic action. If a drug increase noradrenaline in the synapse, it will increase sympathetic action. Okay? So how to manipulate that level? So we have same 3 targets as we discussed in parasympathetic system. And what are the targets? Number one, we can inhibit the rate limiting step. So drug may inhibit the rate limiting step. Here it is tyrosine to dopa. Second, the drug may inhibit entry in the vesicle. If dopamine do not enter the vesicle, it cannot form noradrenaline. And third, we can give a drug which inhibit the exocytosis or release of noradrenaline. So same 3 drugs, remember, we discussed in the parasympathetic system also. So the number 1 drug here is tyrosine. So tyrosine is a competitive inhibitor of enzyme tyrosine hydroxylase. So tyrosine cannot be converted to dopa. So dopamine, noradrenaline will not be produced. So sympathetic action will not come. Okay. And from the name, you can remember the drug very easily. The name of the drug says tyrosine. The drug is saying I am tyrosine. So when the drug is saying I am tyrosine, the tyrosine hydroxylase enzyme gets confused. What is the actual tyrosine? This tyrosine is saying I am tyrosine, and tyrosine is also saying I am tyrosine. So in this confusion, it will not be able to work properly. So competitive inhibitor of tyrosine hydroxylase. Okay. Then second, we have a drug which can inhibit the entry of dopamine into the vesicle. That drug is reserpine. Reserpine. This is the one drug, reserpine. So first drug which was formed that inhibit the entry of dopamine in the vesicle, it is reserpine. Now if we discuss a little detail, this is the first neuron, this is the second neuron. We discussed that vesicle is present here, and we discussed dopamine enters inside and it is converted into noradrenaline here. Now the transporter which will transport dopamine inside the vesicle, this pump here, the transporter here, it is known as VMAT2. VMAT2 is vesicular monoamine transporter. Vesicular monoamine transporter. So from the name you could have easily find out that this is a non-specific transporter. It will transport all monoamines. Monoamine transporter. So all monoamines will be transported into the vesicle by this pump. And what are the monoamines? You know, yes, dopamine is one monoamine. Apart from dopamine, we have noradrenaline, we have serotonin, all monoamines. So all monoamines are transported by this pump. So dopamine, noradrenaline, adrenaline belong to same group, but serotonin belong to a different group. So it not only inhibit the entry of dopamine, but it also inhibit the entry of serotonin, the drugs which inhibit this pump. Okay? So if we see reserpine, which we were talking about, reserpine can inhibit the entry of both dopamine and serotonin in the vesicle. So it can stop the action of both of these substances. So primarily we were using reserpine for inhibiting the entry of dopamine so that action of sympathetic system is reduced. So initially reserpine was developed as antihypertensive drug. So initially we developed reserpine as antihypertensive drug by simple logic that dopamine will not enter the vesicle, it will not produce noradrenaline, noradrenaline will not come into the synapse, sympathetic action decrease, so we can reduce blood pressure. You know, sympathetic system increase BP. So reserpine can be used as antihypertensive drug. In the beginning, around 40-50 years back when we developed that. But after starting reserpine, many of them, they developed suicidal tendencies. Some of them committed suicides also. Then the research was made and find out why this happened. We found that this transporter is non-specific. It not only help in entry of dopamine but also serotonin. So when we give reserpine, even serotonin could not enter. And when serotonin decreases in the brain, that lead to depression. Remember, serotonin is required in the brain to prevent depression. So deficiency of serotonin led to depression, which increased suicidal tendency. So when we came to know that it is causing suicidal tendencies, so reserpine was withdrawn from the market. Okay. Now we have developed new VMAT2 inhibitors. These new VMAT2 inhibitors are, apart from reserpine was earlier. Now we have developed new VMAT2 inhibitors. These include tetrabenazine, deutetrabenazine, and valbenazine. These are also VMAT2 inhibitors, but these are used for a different indication. Basically, these drugs also inhibit the entry of dopamine and serotonin in the vesicle. Okay? But the specific use of the first two drugs, tetrabenazine and deutetrabenazine, it is in the Huntington's chorea. Huntington's chorea. Now, Huntington's chorea occurred due to excessive dopamine in the brain. So when we inhibit this transporter, dopamine deficiency occurs. So these drugs are all known as dopamine depleters because they will deplete dopamine. It will not able to enter the vesicle, so it cannot be stored, so it will be depleted. So Huntington's chorea, we can use tetrabenazine and deutetrabenazine. Whereas valbenazine, it is used in tardive dyskinesia. It is approved for treatment of tardive dyskinesia. So we'll discuss about this condition in the central nervous system when we will discuss antipsychotic drug. It is a side effect of antipsychotic drug, tardive dyskinesia. Okay. So number two drugs we were discussing is reserpine like drug which inhibit the entry of dopamine in the vesicle. Then number three drug which inhibit the release of noradrenaline, that number three drug is guanethidine. Guanethidine, it can inhibit the release of noradrenaline. So when noradrenaline do not come into the synapse, it cannot produce action. So the three drug groups we discussed, metyrosine, reserpine and guanethidine, the final effect of all three is to decrease noradrenaline in the synapse. So when noradrenaline decrease, sympathetic action decrease. So what will be the effect of these three drugs on blood pressure and heart rate? Yes, they are going to decrease it. So all three drugs tend to decrease BP and heart rate. Okay. Then we have number 4 drug which can inhibit the reuptake of dopamine, noradrenaline. So if noradrenaline do not go back, it will stay here. So when it stays in the synapse, it will produce more action. So number 4 drug is opposite to first 3 drugs. That means it is a sympathetic drug, and that number 4 drug example is cocaine. Cocaine is an example of number 4 drug. It inhibits the reuptake of noradrenaline. So noradrenaline do not go back, it stay there, so more action comes. So what will be the effect of cocaine on blood pressure? Yes, it will increase blood pressure. It will increase heart rate. So whereas other 3 drug decreasing, it will increase. Okay. So basically what we discussed, noradrenaline in the synapse is producing the action. If a drug increase noradrenaline, it will increase action, just like cocaine. If a drug decrease noradrenaline, it will decrease sympathetic action, just like tyrosine, reserpine, and guanethidine. Remember, this is very similar to cholinergic system. In cholinergic system also we discussed the similar group of drugs. Remember? So if we compare which is a counterpart drug of tyrosine in cholinergic system, that means which drug is inhibiting the rate limiting step in cholinergic system. What was that? Yes, hemicolinium. Their rate limiting was uptake of choline. So hemicolinium is counterpart of tyrosine. What is the counterpart of reserpine? Drug which is inhibiting entry in the vesicle? Yes, that was visamicol. What was counterpart of guanethid? That means which is inhibiting the release? Yes, botulinum toxin. Remember, we hold the bottle, nothing leaks. And lastly, what is the counterpart of reuptake inhibitor? The drug which is inhibiting the termination. Yes, that were physostigmine like drug, acetylcholine esterase inhibitors. Okay, so these are the drugs which can manipulate the level of noradrenaline in the synapse, and that can change sympathetic activity. Okay, so but finally, this noradrenaline which has come in the synapse, it will work on receptors only. So if we give a drug which directly work on a receptor, that can also produce sympathetic action. So for that, we need to know about receptors. What are the sympathetic receptors, where they are present, and what is their action? So if we come to know about this, then understanding the drugs will become very easy. So now we can move to adrenergic receptors. We will now move to adrenergic receptors. Now, adrenergic receptors are broadly divided into 2 types, alpha receptors and beta receptors. Alpha are further of 2 types, alpha 1 and alpha 2, and beta are of 3 types, beta 1, beta 2 and beta 3. So we'll discuss these one by one, starting from alpha 1 receptors. Now, alpha 1 receptors, in fact, all these receptors are distributed all over the body. Okay? But we will discuss only those locations which are important to remember the uses of various drugs, which are important to remember the normal action of sympathetic system, and which are important for answering the MCQs. So we'll cover everything with that. So although alpha 1 receptor may be present at 100 places in the body, but you need to remember only 3 places. Just remember only 3 places where alpha 1 are present. Number 1, alpha 1 is present in the blood vessels. Alpha 1 is present in blood vessels. What is the effect of sympathetic system on blood pressure? Yes, it increases the blood pressure, we all know. And for increasing BP, what should happen to blood vessel? Yes, vasoconstriction. So alpha 1 is present on the blood vessel and it result in vasoconstriction. When vasoconstriction occur, BP increases. Okay. Then second, alpha 1 is present in the eye. In the eye, what is the effect of sympathetic system on the pupil? Yes, it causes mydriasis. So alpha 1 receptor is the one which cause mydriasis. And number 3, it is present on the prostatic portion of urethra. Alpha 1 is present on the prostatic portion of urethra. And what is the effect of sympathetic system on urine outflow? Yes, it decreases urine outflow. And for decreasing urine outflow, what should happen to urethra? It should contract. So alpha 1 receptor cause contraction of urethra, so urine cannot be passed. So it result in decrease in urine outflow. And which prostatic condition you know in which already there is urinary retention? Yes, it is BPH, benign prostatic hyperplasia. So what should we want in BPH? We want to increase urine outflow. So what we should do on alpha 1? We should block alpha 1. So alpha 1 blockers, they are used in treatment of BPH. Okay. So only these three locations you need to remember for alpha 1. Clear? So just three. What are those three? Number 1, blood vessel vasoconstriction. Number 2, eye mydriasis. And number 3, prostatic urethra decrease urine outflow. Okay. So that is all about alpha 1. Is it okay? Yes. Now moving to alpha 2. Now before going to alpha 2, we'll try to understand one basic thing. This is first neuron. This is second neuron. We know first neuron stores noradrenaline. Whenever nerve impulse comes, it is released. Then it works. And we know these receptors may be alpha or beta. We discussed just now. So normally, whenever we talk about receptors, we are talking about these receptors. So these are called post-synaptic receptors. Okay. But some receptors are present here also. These are called pre-synaptic receptors. And alpha 2 is an example of pre-synaptic receptor. Alpha 2 is present before the synapse. Okay. Now, if we try to understand, suppose you want to drive a car. So if you want to drive a vehicle, you want to drive a car. So what do you want? We will want there should be accelerator on the car. There should be a button of speed. So whenever we press the accelerator, the car will move forward. Okay. So these receptors, they act like accelerator, postsynaptic receptors. So whenever we stimulate them, they will convey the information forward. The action occurs. Okay. But there must be brakes in the car also, because whenever there is risk of accident, we will put the brake. Okay. So if brake is not there, accident will occur. So that brake is done by alpha 2. Alpha 2 receptors, they act like a brake. So what do we mean by brake is whenever noradrenaline increase in the synapse due to any reason, body have compensatory mechanism. Whenever noradrenaline increase, it will start stimulating alpha 2, presynaptic alpha 2. And when alpha 2 is stimulated, it will inhibit the release of noradrenaline. So whenever the presynaptic alpha 2 receptors are stimulated, noradrenaline cannot come down. So it is acting as a brake to noradrenaline. And when noradrenaline do not come down, that excessive activity can be controlled. So this is a physiological control mechanism. And you can say that alpha 2 are brakes to sympathetic system. Although alpha 2 is a sympathetic receptor, but the function is to act like a brake to sympathetic system. Whenever we stimulate alpha 2, there is a brake to sympathetic system. Sympathetic activity will decrease because noradrenaline cannot be released. Okay. So that is main action of alpha 2. But little bit of alpha 2 are present here also. Remember, mostly postsynaptic are alpha 1, but little bit alpha 2 may be present postsynaptically. And whenever alpha 2 is present postsynaptically, that means it forget that I am alpha 2. Means whenever alpha 2 is present postsynaptically, its function is exactly similar to alpha 1. Means what will happen if we stimulate alpha 2 receptor in the blood vessel postsynaptically? If alpha 2 postsynaptic is stimulated, it will work like alpha 1. That means vasoconstriction. What will happen if we stimulate postsynaptic alpha 2 in the eye? Mydriasis. Postsynaptic alpha 2 in the urethra, decrease outflow. So presynaptic alpha 2 act like a brake, but postsynaptic alpha 2 work like alpha 1. But important to remember, these are lesser. Main alpha 2 are presynaptic. So just remember, alpha 2, they act like brakes. Alpha 2 act like brakes. So alpha receptor, you just need to remember this thing. Alpha 1, 3 places, blood vessel, eye and urethra, and alpha 2 brakes. You don't need to remember anything else apart from this. So that completes alpha receptors. Okay, easy. Now coming to beta receptors. We have 3 beta receptors, beta 1, beta 2 and beta 3. Now out of these beta 3, they are mainly present on adipose tissue or fat cells. They are mainly present on adipose tissue or fat cells, and their function is to cause lipolysis. Beta 3 break the fat, they cause lipolysis. So when we came to know that beta 3 is causing lipolysis, so immediately there was a light in our brain. What's that? Yes, we will develop a drug that will stimulate beta 3 and we can treat obesity. It will cause weight loss because beta 3 are breaking fat. So we tried developing a drug which stimulate beta 3 and can be used in obesity. So we kept on trying. We have 40-50 years we are trying, but have not been able to develop any such drug. So beta 3 theoretically it causes lipolysis, but we are not able to develop a drug. But in that development, when we were trying to develop beta 3 agonists, we came to know that beta 3 is also present on urinary bladder. And what will be the effect of sympathetic system on the urine outflow? Yes, it will decrease urine outflow. And when how to decrease urine outflow? Means it relaxes the bladder. So beta 3 on the bladder relaxes the bladder, so urine cannot be passed. So we developed a drug during this process, beta 3 agonist, which stimulate beta 3 receptor, and that was relaxing the bladder. And in which condition will you like to relax the bladder? Yes, in case of overactive bladder. Overactive bladder, remember, urinary incontinence or detrusor instability. So we have developed a drug which stimulate beta 3 receptor and that will relax the bladder, so that will treat this condition. When we relax the bladder, detrusor will stop contracting, so overactivity will stop, incontinence will stop. And the name of that drug is mirabegron. Mirabegron. Mirabegron is a beta 3 agonist that will relax the bladder. And if you want to remember the name in Hindi, you can remember easily. It is saying that Mera bladder gone. Mirabegron. Mera bladder gone. That means my bladder is not working. It is not working means it is relaxed. And that is relaxed by beta 3 agonist. And from the name you can also find the mechanism. It is acting on BE means beta 3 receptors. So mirabegron is beta 3 agonist. Okay, so that is easy. Now another important thing, recently we have developed another drug which is similar to mirabegron. The name of that is vibegron. Vibegron. That was mirabegron, it is vibegron. Both of them are beta 3 agonist. They can be used in overactive bladder. Now tell me, do you remember we studied one more group of drugs which can be used in overactive bladder? Which drugs we discussed? Yes, that were anticholinergic drugs. Anticholinergic drugs, remember we discussed the mnemonic soft bladder. So you can include this drug also and make the mnemonic as makes bladder soft. So these drugs make bladder soft. So all other drugs are same: darifenacin, solifenacin, oxybutynin, flavoxate, tolterodine. These we already discussed. And this drug M for mirabegron and a bivegron new drug. Clear? So this drug is beta 3 agonist and all other drugs are anticholinergic drugs and all of them are used in overactive bladder for urinary incontinence. Okay, so that is about beta 3. So apart from this, we will not discuss beta 3 anymore. We will not discuss beta 3 anymore. So basically we had 3 betas, beta 1, beta 2 and beta 3, and third beta, तीसरे बेटे को हमने घर से निकाल दिया. So now we have only 2 sons, beta 1 and beta 2. So we will discuss only about these two from now onwards. We will not discuss beta 3 anymore. Okay, so we have 2 beta receptors, beta 1 and beta 2, and you can very easily remember we have one heart and we have 2 lungs. So beta 1 is present in heart and beta 2 is present in lungs. Lungs means bronchus. So beta 1 is in heart and beta 2 is in the lungs. Now apart from heart, beta 1 you need to remember only at one more place, and that place is juxtaglomerular cells of kidney. So beta 1 is present in heart and it is present in JG cells of kidney. Rest everywhere we will have beta 2. So first we'll start with the beta 1. If you remember, sympathetic system stimulate the heart and it relaxes everywhere else. And we know in the heart we have beta 1 and everywhere else including lungs we have beta 2. So beta 1 is stimulatory, beta 2 is relaxant. So beta 1 is stimulatory, means what it will do in heart? It will stimulate the heart. How many things in the heart? All three things. So beta 1 will produce increase in heart rate, increase in conduction and increase in contractility. So beta 1 stimulate the heart. Second, apart from heart, it is present in the JG cells. And when we stimulate JG cells, what will happen? Yes, there will be secretion of renin. So beta 1 will help in secretion of renin, that will stimulate the renin-angiotensin pathway. So we all know about that. So beta 1, only two locations you need to remember, heart and JG cells. Okay. Now rest everywhere we have beta 2, including the lungs. So we can write it separately. So beta 2 receptors, it is present in the lungs, means bronchus. Apart from bronchus, it is also present in the GIT. It is present in the urinary bladder. It is present in the uterus. It is present in the blood vessels. It is present in the skeletal muscles. It is present in the liver. So it is present almost everywhere. We have written some of the important locations which I want you to remember. Okay, and we already discussed most of the places beta 2 will relax. Okay, now what it will do on the bronchus? It will relax the bronchus, so that will result in bronchodilation. So beta 2 cause bronchodilation, and bronchodilation is required for which condition? Yes, it is required for asthma. So beta 2 agonists like salbutamol, they are used in bronchial asthma. Okay, then what will it do to GIT? It will relax the GIT, which can result in constipation. Beta 2 will result in constipation. What will happen to urinary bladder? It will relax the bladder, so it will decrease urine outflow. Uterus, it will relax the uterus. And what is the relaxation of uterus known as? Yes, it is known as tocolytic effect. So beta 2 will relax the uterus, and in which condition you will want to relax the uterus? Yes, when the uterus is contracting without purpose. We do not want the uterus to contract, but it is contracting. And what is that condition? Yes, that is known as preterm labor. So in preterm labor, the uterus is contracting before the baby has become mature. You know, uterus should contract at labor at 9 months. When the baby has become 9 months, now the uterus will contract, so the baby will come out. But if the same contraction start earlier, maybe at 6 months, 4 months, 9, 7 months, 7.5 months, that is preterm labor. So beta 2 agonist, they will relax the uterus, so we can postpone the delivery. Okay. Then in the blood vessel also, beta 2 will relax. Relaxation of blood vessel means vasodilation. So beta 2 will cause vasodilation. But hold here. Do you remember alpha 1 were also present on blood vessels? Remember, alpha 1 was also on blood vessel. Now beta 2 is also on blood vessel. And what was alpha 1 doing? Alpha 1 was causing vasoconstriction, but beta 2 is causing vasodilation. So the first question is how to remember which drug cause vasoconstriction and which receptor cause vasodilation. How to remember? So for remembering that, we need to go back to nursery class. And what we were taught in nursery class, we were taught ABCD. Yes, we were taught ABCD. And we were also told counting 1, 2, that was also taught in the nursery class. So if you remember about nursery class, ABCD and counting 1, 2, and just put the arrows now. Just put the arrows, that will solve your question. So A1 means alpha 1. Alpha 1, it cause constriction, means vasoconstriction. So alpha 1 receptor cause vasoconstriction. And beta 2, B2 means beta 2 cause, D means dilation. So beta 2 receptor is causing vasodilation. Okay. So you can remember. So alpha 1 receptor cause vasoconstriction and beta 2 receptor cause vasodilation. Okay. But the question is, out of the two, alpha 1 and beta 2, which is a sympathetic receptor? Very good. Both are sympathetic receptor. So when sympathetic system is activated, which will be activated? Both will be activated. And if both are activated and they have opposite effect on the blood vessels, then what will happen to blood vessel? So when sympathetic system is activated, what will happen to blood vessel? Whether it will contract or it will dilate. What will happen? Yes, it will depend upon a number of receptors. If a blood vessel contain more alpha 1, that will contract. If a blood vessel contain more beta 2, that will dilate. So there will be different effect on different blood vessels. Some blood vessels will contract, some blood vessels will dilate on sympathetic stimulation, because relative number of receptor will be different in different blood vessels. But now the question is, which blood vessel will contract and which blood vessel will dilate? Now to remember that, we will assume a simple story in our mind. Suppose a lion comes in front of you. A lion comes in front of you. So what we can do at this time? So either we can fight or we can run away. Obviously, we are not Rajnikant. We cannot kill lion. We have to run away. So sympathetic system will help us in running away. Remember, lion comes in front of us, so that is an emergency. And the emergency is handled by sympathetic system. So now it is the duty of sympathetic system that we should run away. Now for running away, we will require power in the muscles. Only then we can run quickly. And we require power in the heart so that we do not tire. So sympathetic system will try to increase the power in the muscles and heart. And how it will increase? By increasing the blood flow. So in an emergency, there should be more blood going to muscle and heart. And if more blood has to go to muscle and heart, there should be vasodilation. When the vasodilation occur, only then the blood will go. So sympathetic system will cause vasodilation in the blood vessels of skeletal muscle and in the blood vessels of heart. That means coronary artery. So for causing vasodilation, which receptor should be more? Yes, it is beta 2. So beta 2 is more on the blood vessels of skeletal muscles and blood vessels of heart. So that's why whenever sympathetic system is activated, like a lion come in front of us, more blood will go to heart and muscles. So we can quickly run away. Logical. But the question is, if the more blood is going to muscle and heart, remember, total in the body we have 5 liter of blood. If more is going to muscle and heart, from where does it come? If we have 5 liter of blood, it will remain 5 liter. It will not become 10 liter on single line. If it is 5 liter, then from where this extra blood is coming? The reason is, in this time of emergency, when we have seen a lion, our primary aim will be to run away. Okay? At this time of emergency, we do not require blood on the skin or blood in the internal organs, in the liver, in the pancreas. We do not require blood. So what will happen? Those organs, that means blood vessels of skin and blood vessels of internal organs, that means splanchnic blood vessels, we say, they contain more alpha 1. So that means in the emergency, these blood vessels will contract. So this blood which we have saved, it will go to muscle and heart, and the person can run quickly. Okay? So sympathetic system effect on the blood vessel, you can easily remember ABCD. Remember, alpha 1 cause constriction, beta 2 cause dilation. Number 1. Then number 2, you can easily remember that the blood vessels of heart, that means coronary arteries, and blood vessels of skeletal muscles, they contain more beta 2. Whereas blood vessels of skin and splanchnic blood vessels, or we can say blood vessels of internal organs, they contain more alpha 1. So there will be increased blood flow to the muscle and heart on sympathetic stimulation. There will be decreased blood flow to skin and internal organs on sympathetic stimulation. But remember, the blood vessel to CNS, blood vessel to brain, or we can say blood flow to brain, it do not change. They contain almost equivalent number of alpha 1 and beta 2. So on sympathetic stimulation, blood flow to brain do not change significantly. Okay, so that is about the effect of blood vessels, sympathetic system on the blood vessels. I hope it is okay. Yes. Now next thing is, apart from the blood vessels, the beta 2 receptors are present on the skeletal muscles also. Remember, they are present on the blood vessels of skeletal muscles, yes. But apart from that, beta 2 are present on the skeletal muscle spindle. They are present on the skeletal muscle spindle. And when beta 2 are stimulated on this area, muscle spindle, they result in tremors. So sympathetic system can result in tremors when they are present on the muscle spindle. This is the reason that the tremors occur whenever sympathetic system is activated. Tremors occur when we see a line because sympathetic system is activated. Tremors occur in Viva exams. Remember, in Viva, you start trembling. Why? Because it is an emergency. Sympathetic system is activated, that will stimulate beta 2, that can result in tremors. Tremors occur while proposing someone. Remember, again, same thing. There will be sympathetic overactivity that will result in tremors. So whenever sympathetic overactivity occurs, there is tremors because beta 2 in the muscle spindle are stimulated. Okay. Now, lastly, we will see the effect of beta 2 on the liver. But before going to this, we should try to understand one basic thing. Which is more dangerous, hyperglycemia or hypoglycemia? Which is more dangerous? Let me know. Which is more dangerous, hypo or hyper? Yes, we all know hypoglycemia is more dangerous. The reason is hyperglycemia is seen in which patient? It is seen in diabetic patients. And you must have seen many diabetic patients who have uncontrolled blood sugar. Normal blood sugar is 60 to 110 fasting sugar. Okay. Many patients who are diabetics, their blood sugar is high, maybe 200, 250, 300. And what happens to them? Usually nothing. They even do not know that blood sugar is 200. So they keep on roaming normally here and there for not only 1 day, 2 day, for year, 2 year, 5 years, 7 years, 10 years. They keep on roaming. Nothing happens. Okay? So if anything is not causing any problem for years, that cannot be an emergency. Although after that, these people may develop permanent problems in the kidney, in the eyes and several places. But that thing which is not causing problem for many years cannot be an emergency. Okay. But on the other hand, if hypoglycemia, blood sugar less than 60, it is present for just 1 minute, the person will go to coma. So that is an emergency. So sympathetic system will try to protect from which? Hyperglycemia or hypoglycemia? Obviously hypoglycemia, because sympathetic system, the function is sympathy. It handles emergencies. Now, how a sympathetic system will protect from hypoglycemia? It protect by activating the receptors. So when sympathetic system is activated, it will stimulate the receptors. It will stimulate beta 1, beta 2 receptors. Okay. So when beta 1 is stimulated, that will result in stimulation of heart, that is tachycardia. Beta 1 is in the heart. That can result in palpitations. Palpitations. What is palpitations? Palpitation is awareness of heartbeat. Normally, we are not able to hear our heartbeat. But when we become aware of this, when we are able to listen to heartbeat, that means heart is contracting very forcefully and very quickly. So severe tachycardia leads to palpitations. Yeah? And what they commonly say is, you do not listen to my heart sounds. It's good you are not able to listen. If you are able to listen, that is palpitations. Okay. So tachycardia, palpitation. And we just discussed beta 2 in the muscle spindle cause tremors. Tremors. And we also know sympathetic system in the sweat glands, they release acetylcholine, and acetylcholine stimulate M3, and that can result in sweating. So what do we mean is, whenever sympathetic system is activated, it will cause the symptoms: tachycardia, palpitation, tremors, sweating. So that means they will give a warning that hypoglycemia is present. So these are called as warning symptoms of hypoglycemia. Warning symptoms of hypoglycemia. Remember, which person has more risk of hypoglycemia? It is mostly diabetic. Diabetes does not mean hyperglycemia only. Diabetes means inability to control blood sugar. Remember, a normal person who is not diabetic, like you, suppose. So a normal person, blood sugar is controlled. Suppose a normal person eat too much of sugar. Suppose I eat lot of sweets today. Will I develop hyperglycemia? No, I will not, because body has mechanisms to control blood sugar. It will prevent increase in blood sugar too much. So blood sugar will be maintained. Now suppose I put fasting for a day or 2 days. I do not eat anything. Will I develop hypoglycemia? The answer is no. Again, body has control mechanisms. Okay? The problem is in diabetics, both of these are compromised. Okay? So body is not able to control blood sugar. That means if a diabetic patient eat too much, he will develop severe hyperglycemia. And if a diabetic patient keep fasting, do not take food for 1 or 2 days, he may develop hypoglycemia also. So diabetics have inability to control blood sugar, so they can develop hypoglycemia, number one. And number two, in treatment of diabetes, we are giving a drug that decrease blood sugar. And if a drug decrease blood sugar, there is increased risk of hypoglycemia. Okay, so diabetics are at more risk of hypoglycemia as compared to a normal person. So that's why whenever we want to treat diabetes, we should always give some life-saving advices to this person. This is very important. A diabetic patient come to my clinic. Obviously, I will treat him. I will give him drugs. But before giving the drugs, I will give some advices. And those advices are life-saving for him. What are those advices? Number one, always keep sugar or biscuit with you. Always keep sugar or biscuit or any ready-made source of glucose with you, because these patients have risk of hypoglycemia, and whenever they develop hypoglycemia, they should consume sugar or biscuit. But now the patient will ask you, Dr. Saab, I will keep the sugar with me, but when to take? How will I come to know when I have to take biscuit or sugar? So we will advise them whenever these symptoms come. Remember, these are warning symptoms of hypoglycemia. Hypoglycemia itself says, I am present, please eat something, otherwise you will die. Clear? So these are called warning symptoms of hypoglycemia. So we will advise this person that always keep a check on these symptoms. Whenever there is tachycardia, there is palpitation, there are tremors, there is undue sweating. Clear? So assume that it is hypoglycemia and take sugar or biscuit. Okay. And second advice we always give is, do not skip meals, because that is the major reason of developing hypoglycemia. Person has taken anti-diabetic drug, but person forgot to take meals. There is a risk of hypoglycemia. So a diabetic patient should always continue meals at a regular interval. Do not skip them. And second, they always should keep sugar or biscuit. Whenever warning symptoms come, the person should take. Okay. Now suppose I give you a hypothetical situation. These symptoms, warning symptoms, they are symptoms only of sympathetic system. So whenever sympathetic system is activated, these symptoms can come. Sympathetic system is activated by hypoglycemia, we know. But sympathetic system may be activated by something else also. Like fear can activate sympathetic system. So these symptoms can come. Clear? Now a person is having diabetes. Person is taking anti-diabetic drugs, but the person's blood sugar is uncontrolled. Even after taking the drugs, the person's blood sugar is still 300. Okay? Now, due to some reason, person develops sympathetic symptoms. Suppose the person has fear, anxiety due to any reason. Sympathetic system was activated. The person developed tachycardia, palpitation, tremor, sweating. And immediately this person realizes that my doctor has told me whenever these symptoms are present, you should take sugar. Now the blood sugar is already 300. Should the person take sugar or not? Just let me know. Should the person take sugar or not? Very good. The person should take. Why? Because if the person takes sugar, the blood sugar from 300 may become 350, 340, 380, 400. When 300 is present, 400 are present, nothing much different. But the problem is, if this was hypoglycemia, we do not know whether it is hypoglycemia or something else. But if this was hypoglycemia, that will immediately prevent the person from going to coma. Okay? So what is the advice is, whenever in doubt, take sugar. Okay? So that is very important. So number one thing is, the sympathetic system protect from hypoglycemia by causing warning symptoms. Okay? Now suppose a person comes to a doctor like me who is not aware about anything about this. So person comes to me with diabetes, increase in blood sugar. I give him anti-diabetic drug, I prescribe him insulin, and I do not give him any advice. No advice regarding hypoglycemia, no advice to keep sugar, nothing. Clear? So this person go to home, take insulin, and after that start working. Did not take his meals, and this person developed hypoglycemia. And when the person developed hypoglycemia, there are all symptoms: tachycardia, palpitation, tremor, sweating are present. But person do not know why these are present, and the person do not take food, do not take sugar. If a person do not take sugar or do not take food, even when the person is having hypoglycemia, will the person go to coma? Yes, the person should go, but still the person do not go to coma. Why? Because the nature has made such that the doctor's mistake should not be borne by the patient. So now what happens? If a person do not take sugar, now the beta 2 receptor which are present in the liver, beta 2 which are present in the liver, they will be activated. Liver and muscle, we know liver and muscles are site of metabolism. So when beta 2 is stimulated at these areas, there will be change in metabolism. What is change in metabolism is there will be increase in blood glucose by acting on the metabolic organs. And how to increase blood glucose? So beta 2, it will stimulate the processes which are forming blood sugar like glycogenolysis. The glycogen which is present in the body, it is metabolized to form glucose. Second, it will stimulate the gluconeogenesis. So glucose will be stimulated, formation of glucose will be stimulated from non-carbohydrates. And the process which is consuming blood glucose, that will be inhibited. That means glucose cannot be converted to glycogen. Glycogenesis is inhibited. So basically the processes which are forming sugar are stimulated, which are consuming sugar are inhibited. So net effect will be increase in blood glucose. And when blood glucose is increased, then hypoglycemia is reversed. Okay. So sympathetic system protect from hypoglycemia by two main mechanisms. Number one, by causing warning symptoms. And number two, by causing the reversal. It acts through the metabolism, increase blood sugar. Okay. Now this is the reason that beta blockers are very dangerous in diabetic patients. Beta blockers are very dangerous. What will happen? If a person is having diabetes, person is taking anti-diabetic drug, and now we prescribe him beta blocker for any indication. Suppose the person is having migraine, we want to prevent migraine and we give him propranolol, beta blocker. So what will happen? Beta blockers will block these symptoms. Means whenever the person is developing hypoglycemia, person has taken anti-diabetic drug, person forgot to take meal or due to any reason the person develop hypoglycemia. Normally, whenever hypoglycemia occurs, what happens? The person will develop warning symptoms. Now, when we have blocked beta, warning symptoms were tachycardia, palpitation, tremors. These were the warning symptoms. When the person's beta receptor is blocked, these symptoms will not come. So, what we will say? Beta blockers have masked the warning symptoms. Person is not able to feel the warning symptoms. There will be no tachycardia, there will be no palpitation, there will be no tremors. So other way of asking same is beta blockers cause hypoglycemia unawareness. Hypoglycemia unawareness, the name tells that hypoglycemia is present but the person is not aware. Normally the person become aware because of symptoms. Now because beta blockers have masked the warning symptoms, person is unaware of hypoglycemia, person do not know. Whenever the symptoms come, person will take sugar or biscuit, but now person will not take because person do not know that this is happening. Okay? Now second thing what happens is, if the person do not take sugar, what happens? Liver will reverse. But how liver reverses? By stimulating beta 2, but we have blocked that beta 2 also. So that means now reversal cannot happen. So that means now there is high risk that the person can go to coma. So this is very important that if we give a beta blocker to a person who is diabetic, there is high risk that the person can go to coma due to hypoglycemia. Normally, beta receptors, they cause symptoms, they cause reversal, and beta blocker will stop both of these. There is high risk that person can go into coma. Okay. Now, one last thing. Question asked, which symptom of hypoglycemia still will be present even if a person is taking beta blockers? See carefully, it's very easy. Yes, the only symptom which is reliable is sweating. Remember, sweating is mediated by muscarinic receptor because in the sympathetic system, to the sweat gland, there is a release of acetylcholine. Acetylcholine stimulates M3. And we have blocked beta 1 and beta 2, not M3. Clear? So, beta blockers will not mask the sweating. So, sweating is the only reliable symptom of hypoglycemia. Only reliable symptom of hypoglycemia in a patient taking beta blocker, because other symptoms are masked. Okay? So that's why we always say that you need to be aware about undue sweating. Like, so suppose you are developing sweating in an AC. In an AC room, you are developing sweating. So there may be two reasons. Either you are in love or you have developed hypoglycemia. So if you are not in love, take sugar, otherwise you will die. Okay. So that is important to remember. Role of beta receptors in hypoglycemia. Number one, they cause warning symptoms, and number two, they cause reversal of hypoglycemia. Okay. So that is important about the receptors of sympathetic system. Okay. So quickly we will revise the receptors of sympathetic system. We have alpha 1, alpha 2, beta 1, beta 2, beta 3. Alpha 1 at 3 locations, blood vessel vasoconstriction, and now we know they are more in the blood vessels of skin and internal organs. Number 2, eye, they cause mydriasis. Number 3, prostatic urethra, they decrease urine outflow. Okay. Alpha 2 we discussed are brakes, they stop sympathetic activity. Then beta are three types: beta 1, beta 2, beta 3. Beta 1 is present in heart and GG cells. Remember, we have one heart and two lungs. So beta 1 is in heart and GG cells. They stimulate the heart and they release renin from the GG cells. Beta 2 is present almost everywhere, including the lungs. We know they cause a bronchodilation, they cause relaxation of uterus, they cause tremors, they cause vasodilation, particularly in the heart and the skeletal muscles, and they also cause warning symptoms of hypoglycemia and they reverse the hypoglycemia. Okay. And beta 3 is present in particularly urinary bladder and adipose tissue. They cause lipolysis, and mirabegron like drugs, they cause relaxation of urinary bladder. They are used for overactive bladder. Okay. So these are the important locations and important actions of sympathetic receptors. Okay. So I will advise you to revise them 1, 2, 3, 4, 5, 10 times till you are able to remember them. Remember, remembering them is very important. I have made that easy. I hope you can remember easily, but you need to remember them because all the ANS and almost 80% of CVS and around 20% of CNS is based on these receptors. Clear? So revise them again and again. Any problem? So after discussion about the location and action of receptors, now we can discuss the drugs acting on sympathetic system. So the drugs may be broadly of two types as we discussed in parasympathetic system. So adrenergic drugs and anti-adrenergic drugs, or we can say sympathetic drug or anti-sympathetic or sympatholytic drugs. Okay. So we will start with the adrenergic drugs. Adrenergic drugs, broadly we can divide into two parts. Just like the parasympathetic system, they may be directly acting, they may be indirectly acting. So if you remember the diagram, we know noradrenaline is produced and stored here. So when the nerve impulse come, it is released, it work on the receptors. After that, it is reuptaken. Okay. So directly acting are those which act on these receptors. So direct action on any of the receptors, and indirectly acting are those which act by inhibiting the reuptake. Okay. So we will start with the indirectly acting drugs. Indirectly acting drug, one group we just discussed, they may act by inhibiting the reuptake inhibitors, and one example we already discussed was cocaine. And there is one more group of drugs known as tricyclic antidepressants. They act by inhibiting the reuptake. So we'll discuss these one by one, starting from cocaine first. Cocaine, if you see, the name of cocaine end with cane. And do you remember which other drugs end with cane? Name few drugs like lignocaine, bupivacaine, prilocaine. What are these group of drugs which end with cane? Yes, they are local anesthetics. So cocaine is a local anesthetic. Now, what is special point you need to remember? Local anesthetics normally cause vasodilation. So if they enter the blood, they can cause hypotension. Okay, but cocaine is the exception because its name start with CO. You can remember CO means constriction. So cocaine will cause vasoconstriction. Due to vasoconstriction, it will increase the blood pressure. Okay, so all drugs ending with cane decrease blood pressure, but cocaine increases blood pressure. And from the name you can remember, it is constriction causing cane. Okay, so first special point is cocaine can cause vasoconstriction and increase in blood pressure. Other canes cause vasodilation. Now, apart from anesthesia, Where else you study cocaine? In which subject you study? Yes, we study cocaine in psychiatry or in forensic medicine as an addictive drug. We know cocaine is one of a highly addictive drug. Now, what are the special points about cocaine as an addictive drug to remember? So, first and the most important point to remember about cocaine addiction is a term known as cocaine bugs. What do you mean by cocaine bug is the person who is addicted on cocaine. The person will feel that bugs are running on the skin, insects are running on the skin. Actually, there is nothing. Person is not seeing anything, but person is feeling that thing. Clear? So when something is perceived, but stimulus is not present, that is known as, yes, that is hallucination. So cocaine bug is a type of hallucination. Now, because it is associated with skin, running of insects, so that is known as tactile hallucination. So that is the MCQ asked, which type of hallucinations are seen in cocaine addiction? These are tactile hallucinations. So the person feel that insects are running on the skin, so the person keep on scratching the skin. So cocaine addict patient, you can see the ulcers on the skin, scratch marks on the skin. Okay, so tactile hallucination. Now, second important thing about cocaine addiction to remember are the sympathetic action. Remember, cocaine is a sympathetic drug. Obviously, it inhibits the reuptake of noradrenaline, more noradrenaline. So, in cocaine overdose, if a person inject large amount of cocaine in the blood, that can result in sympathetic excess symptoms. What are the sympathetic excess symptoms? That will be tachycardia, that will be hypertension. So sympathetic symptoms, mydriasis, all these can be seen in cocaine excess. Whenever a person take excessive cocaine, the sympathetic symptoms can come. Okay. Apart from sympathetic system, cocaine can enter the brain. Remember, it's an addictive drug. All addictive drugs should enter the brain. Only then they will cause addiction. So cocaine is an addictive drug. It can cause CNS symptoms like agitation, aggressiveness. All these can come. Okay, so very commonly the question is asked like this, that a person has taken overdose of cocaine and all of the following symptoms can be present in cocaine overdose except. Clear? So they will give some sympathetic symptoms like tachycardia or hypertension or mydriasis, and even in high excess they will cause so much increase in work of heart that a person may develop myocardial ischemia, myocardial infarction. Then there will be agitation, there will be tactile hallucinations, marks on the skin. All these things will be given, but mostly the answer to this question, which is not seen in cocaine overdose, mostly the answer will be bradycardia. Remember, cocaine causes tachycardia, not bradycardia, because it is a sympathetic drug. Okay, and the third important point about cocaine to remember is how cocaine is addicted. First of all, how cocaine is addicted? It is addicted by snorting. Snorting through the nose, the person snorts. You must have seen they keep on the table some powder and then snorts it. Clear? So through the nose it is going. So if a person is snorting cocaine, we know cocaine is a vasoconstrictor. So it can cause constriction of the blood vessels in the nasal mucosa. And if these blood vessels are constricted for a long period, that can cause ischemia. And remember, nose is attached to the palate above. So if there is continuous ischemia for a long time, that can result in palatine perforation. So that is the another important MCQ asked. In which addiction of which drug can result in palatine perforation? So it is cocaine. Okay, so three important MCQs about cocaine. Number one, it is a local anesthetic which increase BP. Other local anesthetic decrease BP. Second, which type of hallucinations are seen? These are tactile hallucinations. And third, which is not seen in cocaine overdose? It is mostly bradycardia is the answer. Remember, sympathetic symptoms are mostly seen. And lastly, which addictive drug cause palatine perforation? It is cocaine. Okay, so all these points are important to remember regarding cocaine. Okay, now coming to second drug, tricyclic antidepressants. So as the name says, in the chemical structure they have 3 cycles and they are used to treat depression. So they also act by inhibiting the reuptake of noradrenaline. So they also have sympathetic effects, and the examples of these drugs are imipramine group of drugs. Any drug which end with pramine, imipramine, clomipramine, desipramine, and the drugs which end with triptyline like amitriptyline, they are tricyclic antidepressant drugs. We'll cover them again in the central nervous system. Okay, so that is the first mechanism of indirect action. Now there is one more indirect mechanism, that is drugs acting by displacement. Drugs acting by displacement. Okay, so we will first try to understand this thing. Now this is a first neuron, this is the second neuron, and we know the first neuron stores noradrenaline. Now every vesicle have some fixed capacity. Suppose, hypothetically assuming, the capacity of this vesicle is to store 100 molecules, and normally all 100 will be the neurotransmitter, in this case noradrenaline. So we assume that the vesicle is storing 100 noradrenaline. Okay, now if we give a drug like tyramine, there is a drug called tyramine. The special property of tyramine is it can enter in the vesicle. Tyramine can enter in the vesicle. Tyramine has the special property of entry inside the vesicle. Okay? Now suppose we give 50 molecules of tyramine. Now already 100 noradrenaline were present in the vesicle. If we give 50 tyramine, so total will be 150 molecules, 100 noradrenaline and 50 tyramine. But we know that it cannot store more than 100. So what will happen? Now tyramine will push noradrenaline into the synapse. Tyramine says that we cannot accommodate here, so you go. So tyramine will push noradrenaline. So when 50 noradrenaline come in the synapse, now they can stimulate alpha and beta receptors. So that can produce sympathetic action. So this action is by displacement. Displacement means the drug enters the vesicle and displaces noradrenaline, or in simple language, pushes noradrenaline into the synapse. So sympathetic action comes. Now my question is, what is left in the vesicle? So 50 tyramine and 50 noradrenaline, that is left. Okay. Now we give second dose of tyramine. If we give 50 more tyramine, 50 tyramine were already present, so they will become 100 tyramine. 100 tyramine and 50 noradrenaline. Again 150. The vesicle cannot store 150. So what will happen? It will push these 50 noradrenaline also into the synapse. So they will again come into the synapse, again sympathetic action will come. Now what is left in the vesicle? All 100 tyramine. Okay. Now if we give third dose of tyramine, 50 more tyramine, they will become 150 tyramine. And we know it cannot store 150. But there is no noradrenaline which can be displaced. So now what will happen? Now tyramine will be pushed. So now instead of noradrenaline, 50 tyramine will come in the synapse. So tyramine will come in the synapse, and what they will do? Nothing. Tyramine cannot stimulate the receptors. So tyramine will come, but action will not come because they cannot act on receptors. So that is the special property of these drugs which act by displacement. What is the property is they will produce action for 2, 3, 4 doses only, and after that there will be sudden decrease in action of these drugs. Okay? So there will be decrease in action of these drugs. Why decrease in action occurs? Because the neurotransmitter is depleted. Okay? So this phenomenon is known as tachyphylaxis. Tachyphylaxis, which is known as rapid development of tolerance. So you can see the word tachy means fast, like tachycardia. Phylaxis means tolerance. So that rapid development of tolerance is called as tachyphylaxis, and that is seen with the drugs acting by displacement. Tachyphylaxis, rapid tolerance. Remember, normally tolerance is slow to develop. Like a person start taking alcohol. It is not that the first day person takes alcohol and next day person will not enjoy with same alcohol. Person has started with the 2 pegs. Next day also if the person takes 2 pegs, the person will still enjoy. Person will get euphoria. But when the person continue to take that 2 pegs again and again for 1 week, 2 week, 3 week, 4 weeks, now the person will not get kick with the 2 pegs. The person will require 3 pegs now. Clear? So normally tolerance which is occurring to the addictive drugs or any drug, it is slow to develop. It takes many months to develop normally. Okay? But here it is occurring with 2-3 doses only. So that special tolerance is known as tachyphylaxis. And the special property of tachyphylaxis is it occurs because of depletion of neurotransmitter in the vesicle. When there is no neurotransmitter, nothing can be displaced. So that will lead to tachyphylaxis. Okay. Now, which drugs act by displacement? Drugs acting by displacement. One drug we already discussed is tyramine. Now, apart from tyramine, the other drugs are ephedrine, pseudoephedrine, and amphetamines. So all these drugs act by displacement: tyramine, ephedrine, pseudoephedrine, and amphetamines. Okay, so all these can show the phenomenon of tachyphylaxis. Now about these drugs, starting with the tyramine. Tyramine is present in large quantities in cheese. Cheese contains plenty of tyramine. Okay, so we will discuss the importance little while later. Next, ephedrine and pseudoephedrine. These are mainly used as nasal decongestants. Now, what do you mean by nasal decongestant is, they, in simple language, we try to understand, they open the blocked nose. Open the blocked nose. What happen is that in common cold, when a person develop common cold, usually person develop coughing. Along with that, there is not blockade of nose. Why nose blockade occurs? You can try to understand in this manner. These are the blood vessels in the nose normally. These are the normal blood vessels in the nose. When the rhinovirus cause infection, they cause vasodilation. Okay, but in a normal person, vasodilation was not there, so there was plenty of space through which air can enter, so person can breathe normally without any problem. Now, when rhinovirus cause vasodilation, now the blood vessels dilate, so it contains plenty of blood. Now this blood vessel has dilated, this blood vessel has also dilated. So because of dilatation of blood vessel, the space for air to enter decreases. So that gives the feeling of blocked nose. Yeah. And we know when vasodilation occur, more blood comes, and accumulation of blood is called, yes, congestion. So this phenomenon is called as nasal congestion. So nasal congestion in simple language means the person will feel that the nose is blocked, but it is due to vasodilation. So when we give a sympathetic drug like ephedrine, pseudoephedrine, they will cause vasoconstriction. And when the vasoconstriction occur, the space for air to enter increases. So the person feel that the nose is not blocked now. The nose has opened. Clear? So that term is known as nasal decongestion. So they have caused vasoconstriction, so congestion has gone away. Clear? So ephedrine and pseudoephedrine are used as nasal decongestants. They are commonly added to cough syrups. Cough syrups, they normally contain the drug to stop cough, but along with that, many contain the ephedrine or pseudoephedrine because they can cause decongestion. Okay. Then the third group of drug are amphetamines. Now, what is special about amphetamine to remember? These can cross the blood-brain barrier. Special drugs, amphetamines, can cross the blood-brain barrier. They can enter the brain. And after entry in the brain, amphetamines produce two important actions. One, they reduce sleep. Amphetamines reduce sleep. And second, they increase attention span. Amphetamines reduce sleep and increase attention span. Now, if you see at these two actions, they are reducing sleep, and they are increasing the concentration ability, increasing the attention span. So it seems like they are ideal drug for exams. You see, the person can study throughout night, person is not sleepy, and the person can concentrate more. So student will think that these are the drugs for us, but no, we do not use them for this purpose, because major reason, they are highly addictive. Amphetamines are one of the highly addictive drugs. And one of the amphetamine, which is known as MDMA. MDMA, full form is methylene dioxymethamphetamine. This is an amphetamine which is used as a rave drug. You know rave drug? So these are the drugs which are used in parties, the drug parties which happens in Goa, So the people are consuming these drugs and enjoying. So that type of drugs are called as rave drug. So MDMA is one of the rave drug. Okay? So I told you these are used in Goa. So at which place in your city they are used? You just let me know when I come there. Okay. Now, amphetamines are rave drug. So you need to remember for MCQ purpose, that's which of the following is a rave drug. The answer can be MDMA. Answer can be full name, methylene dioxymethamphetamine, or answer can be simple amphetamine. So depending upon the option you need to choose. But this example I am giving to tell you that amphetamines are highly addictive. So we cannot use for minor indications like person is not able to sleep, give amphetamine. This is not done. But clinically, we will use amphetamine based on these two actions only. They are reducing sleep, they are increasing attention span. So what are the indication where we will use? One, we will want to reduce sleep. In which condition we will want to reduce sleep? That condition is known as narcolepsy. Narcolepsy is a disease characterized by sleep attacks. In narcolepsy, the patient develops sleep attacks. And when we say sleep attacks, it literally means attacks. The person can suddenly sleep. So you can assume a person is driving a bike and suddenly sleeps. What can happen? Person is swimming, the person sleeps. Yeah? So these sleep attacks can lead to fatal accidents. So in this condition, we have to reduce the number of sleep attacks. We have to reduce the sleep. So here we can use amphetamines. So amphetamines are used in treatment of narcolepsy, and one of the amphetamine-like drug, which is a drug of choice for narcolepsy, is modafinil. Modafinil is drug of choice for narcolepsy. Another new drug similar to modafinil now formed is R-modafinil. It is R isomer of modafinil. Okay? Another drug is solriamfetol. So all these drugs are approved in narcolepsy. Okay, remember drug of choice is modafinil. Now second thing, amphetamines increase attention span. They increase attention span. So we can utilize them in a disease known as ADHD. ADHD, you know the full form? Attention deficit hyperactivity disorder. Attention deficit hyperactivity disorder, commonly seen in children. Now, attention deficit does not mean that parents are not giving attention. Attention deficit means that the child has less attention span, means the child is not able to concentrate on anything for a long period. So the attention span is small. Like a child start playing with some game, playing with a toy. But within 5 minutes, the child get bored. He is not able to concentrate. So when the child is not able to concentrate, child will throw that toy and pick up another one. So he will start playing with that. Again, within 5 minutes, child get bored, threw that and pick another one. Child again get bored, picked another one. Now, how many toys the parents will bring? So after some time, the child will think that I have nothing to play. So the child become aggressive, hyperactive, violent, and start throwing the things here and there. Clear? So that hyperactivity, it is indirect result of inattention because the child is not able to concentrate. So the child become irritable, and due to that irritability, hyperactivity occur. Clear? So the reason of hyperactivity is inattention. So when we give amphetamines, they increase attention span. And when attention span is increased, the child can concentrate better. So the hyperactivity decreases. Okay. So we can use amphetamines for ADHD, and the drug of choice for ADHD is methylphenidate. Methylphenidate is drug of choice for treatment of ADHD. Methylphenidate is a drug of choice. Now it seems paradoxical that amphetamines are CNS stimulant. Remember, any drug which decrease sleep, increase attention span is stimulating the brain. And in this condition, the child is already hyperactive. So it seems totally opposite. Like if a child is hyperactive, obviously I will not like to stimulate the brain. But we are giving amphetamines, they are drug of choice. So why we are using? If we understand that the basic problem is not hyperactivity, the basic problem is inattention. So amphetamines increase the attention span, so indirectly decrease hyperactivity. Okay, so we use ADHD. For ADHD, we use amphetamines, or the drug of choice is methylphenidate. Okay, so that is important about indirectly acting sympathetic drugs. So two groups we discussed, one which inhibit reuptake and second which act by displacement. Okay, so now we will move to the very important group of drugs which are directly acting. So they will directly stimulate any of the sympathetic receptors, alpha 1, alpha 2, beta 1, beta 2, beta 3, any of them. Okay? Now directly acting drugs, we can further divide into two groups. One is called as catecholamines and second is called as non-catecholamine. So directly acting drugs we can divide into catecholamines and non-catecholamines. My first question will be, what do you mean by catecholamine? What is catecholamine? Yes, I know adrenaline, noradrenaline, they are catecholamines. But what is meaning of catecholamine? When we say the drug is catecholamine, catecholamine is a chemical name. Now, if you see that it consists of two parts, catechol and amine. Now, go back to the chemistry. In chemistry, we discussed 11, 12th, we studied that this is benzene. And if we attach two hydroxyl group on benzene, this structure is called as catechol. So that means any drug having this type of structure is having catechol nucleus. And if amine group is also present on this drug, it is called as catechol amine. Clear? So any drug having this type of chemical structure in which catechol nucleus is there and amine group is there, that is called as catecholamine. Now, important thing is you don't need to remember this structure. This is just I am showing my knowledge. Now, what is important? We have discussed already several drugs, but we never talked about chemical structure. But here we are talking about chemical structure, so there must be something important. And what is important is this structure can be recognized by some enzymes in the body. And the name of that enzyme is COMT. The full form is catechol orthomethyl transferase. So this enzyme can recognize the catecholamine nucleus, catecholamine structure. So any drug having this type of chemical structure can be broken by COMT. And the problem is there is plenty of COMT in RGIT. RGIT contains large concentration of COMT. That means if we give any catecholamine orally, already COMT is waiting in the GIT. So whenever we give orally, COMT will break it down. Or in simple language, we can say catecholamines are not effective orally. Catecholamines cannot be given orally. That is the clinical importance you need to remember. Whereas non-catecholamines can be given orally, but depending upon their own properties. If a drug is absorbed through the GIT route, they can be used. Non-catecholamines are not broken by COMT. Clear? So that is the basic thing you need to remember, that catecholamines cannot be given orally. No catecholamine is effective orally. Okay, so we will start with the catecholamines. First, we will discuss these and then we will move to non-catecholamines. Okay, starting with catecholamine. Now, catecholamines, already we discussed that they are not effective orally. Now, broadly, we can further divide them into two parts. They may be endogenous catecholamines. Endogenous means they are normally present in the body. And they may be exogenous, means normally they are not present in the body, they are given only from outside. Okay, and endogenous catecholamines we all know. What are the endogenous catecholamines? They are adrenaline, noradrenaline, and dopamine. They are normally present in the body. Now, exogenous catecholamines include dobutamine, dopixamine, and isoprenaline. And one more drug you can add is phenoldopam. So all these are exogenous catecholamines. So remember, all of these drugs are injectable. They cannot be given orally because they are broken by COMT in the body. Okay. So now we will discuss these drugs one by one. So starting with dopamine. First we'll discuss about dopamine. Now if you see dopamine, we write here. For understanding about any drug, first thing we need to know is on which receptors it works. If we come to know that, we can come to know about lot of things. Okay. Now dopamine, it stimulates three receptors, D1, beta 1 and alpha 1. Dopamine stimulates three receptors, D1, beta 1, alpha 1, and important to remember is the sequence. It stimulates in this sequence. What is the meaning of sequence is, at low dose, it stimulates only D1. When we increase the dose, it starts stimulating beta 1 also. That means it stimulates D1 and beta 1. And at high dose, it will stimulate all three receptors. And if you remember the dose for beta 1, the other two you can automatically remember. So the dose for beta 1 is 2 to 10 microgram per kg body weight per minute. So we give at this rate between 2 to 10, it can stimulate beta 1. Means if we give less than 2, it stimulate only D1. And if we give more than 10, then it can stimulate all three receptors. So dose dependent effects of dopamine are there. This is, you need to remember. Remember at other places when I am talking about doses, that were only an example. But here you need to remember the dose. This is the actual dose. So less than 2 only D1, 2 to 10 D1 and beta 1, and more than 10 all three. Remember, when the dose increases, the earlier receptor will not stop. That still can be stimulated. The receptor which can be stimulated at low dose obviously can be stimulated at high dose also. Okay, so this is the sequence. But first of all, we'll try to understand where these receptors are present. So we already discussed beta 1. Beta 1 is present in, yes, it is present in heart. So dopamine can stimulate the heart. Alpha 1 is present in the blood vessels. When we stimulate, it can cause vasoconstriction. That can increase blood pressure. But we did not discuss about D1. Where this is present? Yes, D1 is also present in the blood vessels. But the action is to cause vasodilation. Effect of D1 is to cause vasodilation. But important thing to remember, D1 is present in every blood vessel of the body. It is present everywhere, all the blood vessels, but its highest concentration, maximum concentration is in the renal blood vessels. It is not that it is not present in other blood vessels, but in the kidney it is predominant receptor. So in the blood vessels of kidney, D1 is main. Okay. So if you see that, where we can use dopamine. Dopamine stimulate beta 1. So we can use dopamine for stimulating the heart. And stimulating the heart is required in congestive heart failure. So as the name says, heart failure. Heart is not properly contracting. So when heart is not contracting, we want to increase contractility. That can be done by dopamine. So if the question is asked, what is the dose of dopamine for treatment of congestive heart failure? Yes, it is between 2 to 10. So at that dose, it can stimulate beta 1. So that will treat CHF. Now, dopamine can cause vasoconstriction, and vasoconstriction will increase blood pressure. So we can use dopamine for treatment of shock also. Remember, in shock, we want to increase blood pressure. And another important thing to remember, dopamine is used in shock. Which shock it is used? Whenever we want to cause vasoconstriction. Like in septic shock, there is vasodilation, we can use dopamine. But dopamine will not be that much effective, or any vasopressor will not be that much effective in hypovolemic shock, when the shock is due to loss of blood. So obviously we will replace the fluids in that case. So primary treatment in hypovolemic shock is fluid replacement. We can give ringer lactate, or sometimes blood is also required, but vasopressor will be mainly used when the shock is vasodilatory shock, as in case of septic shock. So dopamine can be used in shock also. Yeah. But will be the dose of dopamine for treatment of shock? Yes, it is more than 10. So see carefully, the dose of dopamine for treatment of shock is higher as compared to treatment of congestive heart failure. Okay, so we can use dopamine in shock. But for shock, we can use any drug which cause vasoconstriction. Like we can use even phenylephrine, which is alpha agonist. So any drug which cause vasoconstriction, we can use in shock. What is the special about dopamine? Dopamine is specially preferred in a condition in which shock is present along with oliguria, low urine output, or in simple language, kidney failure. Now, first question is, we were talking about shock. Now, from where the kidney has come? If you work in surgery emergency, a patient comes to you with loss of blood, or a patient comes to you with any condition in which there is shock, BP is low. The first thing which the SR see you to do is, what the SR say? Check the urine output. Now, question is, we are talking about shock, then why we are concerned with urine output? The reason is, in any type of shock, there is low BP. And when the BP is low, the pressure is low. And when pressure is low, the pressure gradient will be low. Remember, the urine output filtration will depend upon pressure gradient. And if the pressure already is low, there will be low gradient. So there will be decreased urine output. There will be start of renal failure. So the shock predisposes the patient to renal failure. So till the time there is no renal failure, there is shock without oliguria, we have only one aim, that is to increase the blood pressure. So that we can increase by giving any vasopressor. But if the kidney failure has started, person has shock with oliguria, now we have two aims. First, we want to increase BP. Second, we want to increase blood flow to kidney. Remember, we want vasodilation in kidney. Vasodilation occur, more blood will come. then oligouria can also be reversed. So dopamine is a drug of choice now because when we give high dose, that means more than 10, it stimulates all the three receptors. By stimulating alpha 1, it will increase the BP, so it will take care of shock. But at the same dose, it is stimulating D1 also. So D1 is causing renal vasodilation. So blood flow to kidney also increase. So BP also increase, but blood flow to kidney also increase. So shock is also treated. Oligouria is also treated. That's why it is a drug of choice. So drug of choice for shock with oligouria. Okay. So that is important about dopamine. But last thing you need to remember, or you can try to remember by this manner, among the catecholamines which we are discussing, any drug which contains a dopa in the name, that can stimulate D1 receptors. If dopa is not in the name, the drug cannot stimulate D1. That is our mnemonic. Remember, name contains a dopa, drug will stimulate D1. Name do not contain dopa, it will not stimulate D1. Now, why I am talking like this? The second drug we are going to discuss is dobutamine. The name is very similar to dopamine. But if you read the name carefully, there is no dopa. So dopa is not in the name, so it do not stimulate D1 receptors. It has no action on D1 receptors. Remember, dopamine stimulate D1, but dobutamine do not stimulate a D1 receptor. Rather, dobutamine has main action on beta 1 receptors. Dobutamine has primarily action on beta 1 receptors. And in which condition you will want to stimulate beta 1? Yes, in case of congestive heart failure. So we can use dobutamine for congestive heart failure. Remember, this question is very commonly asked in the MCQs, that all of the following statements are correct about catecholamines except. And one of the option they gave, which is mostly the answer, is dobutamine is a strong D1 agonist. The answer is, this is wrong statement. Remember, dobutamine do not act on D1. So how you can remember whether the name contain dopa or not? Its name do not contain dopa, so it cannot act on D1. Okay, so dobutamine is primarily used for CHF. It is a strong beta 1 agonist. And when it stimulates the beta 1, it increases the contractility, we can use in CHF. Okay. Now, if you see the next drug, phenoldopam. If you see the drug phenoldopam and see carefully, its name contain dopa. Its name contain dopa means it can stimulate D1 receptor. Phenoldopam can stimulate D1 receptor. Now we will read this name again and again 3, 4, 5 times. We will say it phenoldopam, 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 phenoldopam. It look like we are saying only dopa, only dopa, only dopa. So that says that it stimulates only D1 receptor. Remember, dopamine at high dose starts stimulating beta 1 alpha 1 also, but it stimulates only D1. And what was the role of D1? D1 was causing vasodilation. So D1 was causing vasodilation. So even at high dose, it stimulates only D1, so only vasodilation. Remember, when we give dopamine in high doses, it starts stimulating alpha 1 also, and alpha 1 causing vasoconstriction. But even at high doses, low doses, it stimulates only D1. And when only D1 is stimulated, vasodilation will occur, and vasodilation will decrease the blood pressure. So where we will use phenoldopam? When we want to decrease blood pressure, so it will treat the hypertension. So phenoldopam is used for hypertension. Now, can we use phenoldopam for routine hypertension? A person has come to you with blood pressure of 140 by 90 millimeter of mercury. Will you like to give phenoldopam? Answer is no. I know answer is no. The question is why? Why we don't give phenoldopam for routine hypertension? Because phenoldopam, where we are studying in the catecholamines, it is a catecholamine. And what is the problem with catecholamine? We cannot give orally. So none of these drugs is effective orally. So we need to give IV. And will a person like to take IV injection for mild increase in blood pressure? So obviously not. We will not like to give. So in mild BP, we will give oral drugs. So it will be used when we have to give IV. That means in hypertensive emergencies. So phenoldopam is indicated in hypertensive emergencies only, not for routine hypertension. Okay. Then another drug, if you see, the name of the drug is dopixamine. Dopixamine, if you see carefully, it contains DOPA dopa. So it also contains dopa, means it can also stimulate D1 receptor. Now, apart from stimulating D1 receptors, it can stimulate the beta 1 and beta 2 receptors also. It is a very strong agonist on beta 2 receptors. Okay? So it stimulates D1, beta 1 and beta 2 receptor, and this drug is also used in congestive heart failure. Okay. So now we are left with the three drugs: adrenaline, noradrenaline and isoprenaline. We will discuss them together. So we are going to discuss about three drugs: adrenaline, noradrenaline and isoprenaline. Now, first of all, for remembering anything about the drugs, we need to know on which receptors they were. And remembering that is very easy. So you can say A for adrenaline, A for all the receptors. All the receptors means it can stimulate alpha 1, alpha 2, beta 1, beta 2. Adrenaline stimulate all four receptors. Then NA is noradrenaline. Noradrenaline means not all four. That means it stimulate first three receptors, alpha 1, alpha 2 and beta 1. It do not stimulate beta 2. Okay? So you can remember that noradrenaline is written as NA, noradrenaline. So when we start writing alpha 1, alpha 2, beta 1, suddenly we remember not is also written. So when not is also written, we will stop here. So we will not write beta 2. So it do not work on beta 2. And isoprenaline, you need to remember, act only on beta 1 and beta 2. It do not act on alpha receptor. Okay? So adrenaline all, noradrenaline not all, means beta 2 is not there, and isoprenaline only beta is there, alpha is not there. Okay. Now, before going to the actions of these, we need to understand some basic things. Like you must have heard, like we are discussing a drug, adrenaline. Now, there is another drug known as epinephrine. So my question is, what is the difference between adrenaline and epinephrine? What is the difference? Very good. There is a difference of spelling only. They are same drug. In some countries, it is called adrenaline, and in other countries, it is called epinephrine. Similarly, noradrenaline and norepinephrine are same thing. Do not get confused. Adrenaline or epinephrine are same. Noradrenaline, norepinephrine are same. Now, second question, what is the meaning of this nor? You will find nor written in front of many drugs like adrenaline, noradrenaline, verapamil, norverapamil, pethidine, norpethidine. So there are many substances which contain nor in the name. What do you mean by nor? Nor actually mean is NO means no, means absent. R is the symbol of alkyl group. So from the chemical structure, if we remove the methyl group, that become nor. Like if adrenaline is there, means there is methyl group on the nitrogen. Methyl group is present on the chemical structure. If we remove that methyl group, it will become noradrenaline. Okay? So if we want to convert adrenaline to noradrenaline, which is the enzyme involved? Yes, it is demethylase. Similarly, if we want to convert noradrenaline to adrenaline, we have to attach the methyl group on nitrogen. So the enzyme is N-methyl transferase. So enzyme will transfer the methyl group on nitrogen. Okay. So nor means absent methyl group. Okay. So that is the basic thing. You don't need to remember. I am showing my knowledge again. Okay. So basically, adrenaline stimulate all receptors, noradrenaline first three, and isoprenaline only beta. So now we can see the action of these three drugs or effect of these three drugs on blood pressure and heart rate. Okay. So we will write again adrenaline, noradrenaline and isoprenaline. And we are going to see the effect of these drugs on blood pressure and effect of these drugs on heart rate. Okay. Now, one thing which is important to remember, blood pressure is of two types, systolic BP and diastolic BP. Now, first of all, what do you mean by systolic blood pressure? What do you mean by systole? Systole means contractility, contraction of heart. So if a heart contract more powerfully, so ventricle contract, so blood will be forced out. So it will come with more pressure. So that blood pressure is systolic blood pressure. Okay. So systolic blood pressure depend upon contractility of heart. And which receptor increase contractility of heart? What is the receptor on the heart? Yes, beta 1. So systolic BP, it depend upon beta 1. So if a drug stimulate beta 1, it will increase systolic blood pressure. So now we will write which receptors are stimulated by them. Adrenaline, we discussed A for all, means alpha 1, alpha 2, beta 1, beta 2. Noradrenaline, not all, means alpha 1, alpha 2 and beta 1. And isoprenaline, only beta, beta 1 and beta 2. So if you see all the three drugs, they are stimulating beta 1. So beta 1 stimulated here, here, as well as here. So what will be the effect of these drugs on systolic BP? Remember, systolic BP, we want to stimulate beta 1. All three are stimulating. So all three drugs increase systolic blood pressure. Easy to remember. So systolic blood pressure increased by all. Now coming to diastolic blood pressure. Diastolic blood pressure means after the heart has contracted, it will relax. Now when the heart is relaxed, still there will be some blood pressure. So that blood pressure is called diastolic blood pressure. So diastolic blood pressure means when the heart is relaxing. So when the heart is relaxing, which factor maintain the blood pressure? When the heart is relaxing. So that will depend upon total peripheral resistance. I don't understand the fancy terms. Tell me the meaning of this. Meaning of this is, what is the status of blood vessels? If the blood vessel is constricted, the BP will be more. If the blood vessel is dilated, BP will be less. So it will depend upon diameter of the blood vessel. If there is vasoconstriction, more BP, vasodilation, less BP. Okay? And on the blood vessel, which receptors are present? Yes, remember nursery class ABCD. Alpha 1 cause vasoconstriction, beta 2 cause vasodilation. We discussed on the blood vessel, these two receptors are present. So if a drug stimulate alpha 1, it will cause vasoconstriction, so it increase diastolic BP. If a drug stimulate beta 2, it will cause vasodilation, so it will decrease diastolic BP. Okay? So we'll see the effect of drugs now. So if we talk about adrenaline, by stimulating alpha 1, it causes vasoconstriction, so it tend to increase diastolic BP. But at the same time, it stimulates beta 2 also, which cause vasodilation, that tend to decrease diastolic BP. So net effect is they cancel each other. So there is negligible effect on diastolic BP. Remember, diastolic BP will depend upon action of alpha 1 and beta 2. When both are stimulated, negligible effect. Negligible, remember, not zero. Slight increase, slight decrease may happen depending upon whichever is predominant. Okay, but it will not be very much. Then coming to noradrenaline, it stimulates alpha 1 that cause vasoconstriction, but it has no beta 2 action. So that means only vasoconstriction. When only vasoconstriction means increase in diastolic BP, so it increases diastolic BP. Okay, if we see isoprenaline, there is no alpha action, but it stimulates beta, and beta 2 cause vasodilation will, and when vasodilation occur, BP will decrease. So isoprenaline will decrease diastolic BP. Is it clear? So adrenaline, it increase systolic BP as well, but no effect on diastolic BP. Noradrenaline increase systolic as well as diastolic. Isoprenaline increase systolic but decrease diastolic BP. Okay. Now we will come to heart rate. When we talk about heart rate, we always need to talk about two things. What is the direct effect on the heart and what is the indirect effect on the heart or reflex effect on the heart. So starting with the direct effect, when we say direct effect means drug will directly go to heart and produce something. Okay. So on the heart, which receptor is present? Yes, it is beta 1. So if a drug stimulates beta 1, it will increase heart rate. You all know. So direct effect means directly act on the receptor on the heart. So beta 1 is present in all three, we already discussed. So all three drug will tend to produce directly increase in heart rate. All three will increase. Now the question is, what is the meaning of indirect effect? What is indirect? So this indirect effect you can understand by understanding that our body has compensatory ability for everything. If anything wrong goes in the body, body will try to rectify. So if BP increases, body will try to decrease. If BP decrease, body will try to increase. So that is the normal physiological thing. Body try to reverse any change in itself. Now the question is, when the body have to adjust, when the BP increase, body have to decrease. When the BP decrease, body has to increase. But for that, body should know first whether the BP has increased or decreased. So there must be some sensors in the body which tell that the BP has increased, we have to decrease. There are some sensors which can tell that BP has decreased, so you need to increase. And what is that sensor called? That sensor is called baroreceptors. So baroreceptors are the receptors which will sense the blood pressure. And where the baroreceptors are present? Yes, they are present on the blood vessels. So this is a blood vessel. This is the presence of baroreceptor. Baroreceptor is present. Now, whenever BP increases, baroreceptor will sense. But the question is, which blood pressure is sensed by baroreceptor? Systolic BP or diastolic BP? You can easily remember where they are present. on the blood vessels. And blood vessel control which BP? Diastolic BP. So they mainly sense diastolic BP. Remember, although they are sensing the mean blood pressure, but mean blood pressure, if you remember physiology, the formula is diastolic BP plus 1/3 of pulse pressure. So the main contribution of mean BP is diastolic BP. Okay? So baroreceptors, you can remember for understanding the concept that they sense diastolic BP. Okay, so whenever diastolic BP increase, baroreceptor get the information. So now they have got the information that BP is high and we want to reduce this BP. So baroreceptor will immediately pass this information to CNS. Remember, we have only two arms, sympathetic and parasympathetic, that can control. So first of all, the CNS get the information, brain and spinal cord, they are sitting here, they should get the information. So when baroreceptors are stimulated, they will take the information. So where they will take the information, which system we want to stimulate. Remember, BP is high, we want to reduce BP. And for reducing BP, which system you will want to stimulate, sympathetic or parasympathetic? Tell me. Yes, we will want to stimulate parasympathetic system. So baroreceptors will stimulate the vagus nerve, parasympathetic nerve. So parasympathetic nerve will immediately go and depress the heart. So it will decrease the heart rate. Okay. So that is the indirect effect on heart. Okay? The opposite also you can discuss, like if the diastolic BP is low, baroreceptor again get the information. But now we want to increase BP, so they will pass this information to sympathetic system. So sympathetic system, what they will do, it will stimulate the heart, so heart rate will increase. Okay? So that is the indirect effect on heart rate. So you can see that whenever diastolic BP increases, the indirect effect is to decrease heart rate. Whenever diastolic BP increases, indirect effect is to decrease heart rate. Whenever diastolic BP decreases, the indirect effect is to increase heart rate. So very simple language, you can understand that indirect effect on the heart rate is opposite to diastolic BP. Opposite to diastolic BP. So whatever happened to diastolic BP, the heart rate will be affected opposite. If BP increases, heart rate decreases. If BP decreases, heart rate increases. Now we can apply this knowledge. If you see, what is the effect of adrenaline on heart rate? No effect. So there will be no reflex. If the heart rate increases, this diastolic BP increases, the heart rate will decrease. If the diastolic BP decreases, the heart rate will increase. So this is the opposite to normal effect on diastolic BP. So if you see the final effect, what is the final effect on the heart rate? Remember, directly or indirectly, both they are affecting heart rate. So final effect you can easily find out by simply doing the sum of these two. Sum of direct and indirect effect, and you can see 1 plus 0 is 1, 1 minus 2 is minus 1, and 1 plus 2 is 3. So what we note, adrenaline increase heart rate, noradrenaline decrease, and isoprenaline also increase heart rate. Okay? So this table is very important for MCQs. So the question can be asked in the form of diagram. They will give you a graph and they will tell you to identify which is the drug. Okay? So they are saying after giving a drug, this effect is noted. Like I'm making a diagram here. So systolic blood pressure, what they say, this is the control. After giving the drug, this happens. When the effect of drug subsides, again normal. Diastolic BP, after giving a drug, this is normal, and this is after giving a drug. And heart rate, this is normal. After giving the drug, this happens. So which is the unknown drug? So I will make 3 graphs. This is one. The second is systolic BP increases like this. Diastolic BP also increases like this. And heart rate decreases like this. So this is the time where we give the drug. This is the time where we give the drug. This is the time. Okay. Now the third graph is systolic BP increases like this. Diastolic BP decreases and heart rate increases. Okay. So tell me which are these 3 drugs. This drug is, yes, this is adrenaline. Remember, systolic BP increases, negligible effect on diastolic BP, heart rate increases. This is noradrenaline. systolic and diastolic both BP increase but heart rate decrease. And this is isoprenaline, systolic BP increase, diastolic decrease, heart rate increase tremendously. Clear? So from the graph also you can answer the question. The same thing in the form of graph they have made. Okay. Now some important MCQs which can be asked from this table apart from direct graph type of questions. So they can ask directly, which drug increase systolic and diastolic BP but cause bradycardia? It is noradrenaline. Okay. Now one question which seems very simple, but 99% of chance that you will mark wrongly in the exam. What is that question? Very simple question. What is the effect of noradrenaline on heart rate? So what is the effect of noradrenaline on heart rate? It will cause bradycardia, decrease heart rate. When the answer is so simple, why you will mark wrongly? Because in the exam the table is not in front of our eyes. At that time, what is our thinking? Noradrenaline is a sympathetic drug. So when we give noradrenaline, sympathetic system is activated, so heart rate will increase. Okay? So simple question. But we are marked wrongly. Remember, the indirect effect is very strong. Directly tend to increase heart rate, but indirect effect, parasympathetic effect is so strong that heart rate decreases. Okay, so read carefully. Exogenous noradrenaline IV administration cause bradycardia, not tachycardia. Okay, now same question, slightly difficult. What is the effect of noradrenaline IV infusion, exogenous noradrenaline IV infusion in a patient with a transplanted heart? What is the effect on heart rate? Now, important thing to understand is, what is the difference between a normal heart and a transplanted heart? To answer this question, we want to know this. So, what is the difference between a normal heart and a transplanted heart? There is no difference. Dil to hai dil, heart is heart. So, what do we mean is, a normal heart also contain beta 1 and a transplanted heart will also contain beta 1. Obviously, we will not remove beta 1 one by one and then we will transplant. So beta 1 is present in both hearts, normal heart as well as transplanted heart. What do we mean is, the direct effect will continue in both cases. So that means directly in a normal person also tachycardia occur, in a patient with the transplanted heart also tachycardia happens. But the important thing is, when we are making a transplant of heart from one person's body into another person's body, we cannot make every neural connection. We can make the big connections, aorta we will attach, main nerves will attach, but we cannot make attachment of the autonomic nerves which are very small. So we cannot attach sympathetic nerves, parasympathetic nerves, these are not attached. So what we say, heart transplant, or we can say transplanted heart, it is also known as denervated heart. Transplanted heart is also called as denervated heart. And what we want to know is, when a heart is denervated, now there will be no reflexes. Even if baroreceptors are stimulated, they give the information to parasympathetic system, but the parasympathetic nerve is not coming to heart. So indirect effect cannot come in a transplanted heart. In a transplanted heart, these actions will not come. Only direct effect will come. So what will be the effect of noradrenaline on heart rate in a patient with a transplanted heart? Only this action, that means tachycardia. Remember, noradrenaline normally causes bradycardia, but in a transplant patient, it will cause tachycardia. Okay. The same question in third format. What is effect of noradrenaline on heart rate in atropinized heart? Means a person has already been given atropine. Now we start noradrenaline. What will happen to heart rate? For that, we need to find the connection between noradrenaline and atropine. Now, what atropine does? Atropine is anticholinergic. It stops the parasympathetic system. Now, in the action of noradrenaline, where parasympathetic system comes? Remember, direct effect is on beta 1. No parasympathetic. But what is this indirect effect? This indirect effect is because of parasympathetic system. Remember, parasympathetic system. So when person has already received atropine, means parasympathetic system cannot work. So that means again the indirect effect cannot come. So when the indirect effect do not come, means only direct effect come. So it will lead to tachycardia. Okay. So what are the important thing to remember? Noradrenaline in a normal person, it will cause bradycardia. But noradrenaline, if we give in a transplanted patient, it will cause tachycardia. And same if we give noradrenaline to person with atropinized heart, where we have already given atropine, still it will cause tachycardia. Okay, this is the effect of noradrenaline in a normal person, in a transplanted person, and in a person with atropinized heart. Okay. Now, apart from this, you can also find some more things. If you see carefully, if the question is asked, which of the following drug cause maximum increase in pulse pressure? Pulse pressure. So what is pulse pressure first? Tell me, what is pulse pressure? It is systolic BP minus diastolic BP. That is pulse pressure, the difference between systolic and diastolic. So if we assume that normal blood pressure is 120 by 80, the upper is 120, lower is 80. So this gap is pulse pressure. 120 minus 80, the 40 is the pulse pressure. Okay. So this is in a normal person, we assumed, without giving any drug. Now we give one by one the drug and see what happens. Adrenaline. When we give adrenaline, if you see the table, adrenaline increase systolic BP. But adrenaline has no effect on diastolic BP. It remains same. So systolic BP increase, diastolic same. So what happened to pulse pressure? So adrenaline increase pulse pressure. Okay. Now coming to noradrenaline. This is the normal again. When we give noradrenaline, systolic BP increase, but diastolic increase too much. So what happened to pulse pressure? It is reduced. So noradrenaline decrease pulse pressure. Okay. Now coming to isoprenaline. This is the normal BP. When we give isoprenaline, systolic increase and diastolic decrease. So what happened to pulse pressure? There is a big margin. So pulse pressure increase significantly in isoprenaline. Okay. So that is effect of different drugs on the pulse pressure also. Okay. So this table and the graphs related to this table and plus special points, they are important for MCQs. Okay. So with that, now we can discuss the uses of these drugs. So again, we will write adrenaline, noradrenaline, and isoprenaline. They act on A for adrenaline, A for all the receptors, and A for noradrenaline on first three receptors, not all, and iso only beta. So from the receptor, you can tell the major uses, like starting with the noradrenaline. It stimulates alpha 1 receptors. Alpha 1 is causing vasoconstriction, so we can use it in shock. Noradrenaline is used in shock. In fact, noradrenaline is a drug of choice for septic shock. For septic shock or any vasodilatory shock, the drug of choice is noradrenaline. Okay. Now it can stimulate beta 1. So beta 1 we want to stimulate in congestive heart failure. So we can use noradrenaline for CHF also. Now sometime the question is asked, very simple question. A patient has been admitted in the hospital with septic shock, means BP is low, and you start the drug of choice, that means noradrenaline, by intravenous infusion. You have started intravenous infusion of noradrenaline. Now how will you check whether noradrenaline is effective or not? How will you check for the efficacy of noradrenaline in this patient, whether it is working or not? Okay. So there will be four options. One option will be increase in blood pressure. Second option will be decrease in heart rate. So which will you check? Very good. Keep it simple. Why we are giving noradrenaline? To increase BP. So check BP. If the BP is increasing, that means it is working. If it is not increasing, it is not working. So do not make complications. Why we talk about heart rate? We want to increase blood pressure. So look at BP. So we will check the progression by measuring the mean blood pressure. If it is controlled, means the drug is working. Okay. So that is noradrenaline. Then isoprenaline, again you can find it stimulate beta 1. So we can use in congestive heart failure. Stimulate the heart, so we can treat CHF. But it stimulate beta 2 also, and we know we have one heart and two lungs. So beta 2 cause bronchodilation, so we can use it in bronchial asthma. Although we do not prefer nowadays, because for asthma we have selective beta 2 agonists like salbutamol. But in emergencies, if nothing is available, we can use isoprenaline. So can be used in asthma. Okay. Now adrenaline. Do not write, just listen. Theoretically, by stimulating alpha 1, it increases blood pressure, so we can use in shock. It stimulates beta 1, we can use in congestive heart failure. It stimulates beta 2, we can use in asthma. But practically, we do not use adrenaline for any of these. The question is, when we can use in all of them, then why we are not using adrenaline? The reason is adrenaline is very, very toxic drug. So when we give intravenous adrenaline, there is high chance of arrhythmias and the person can die. So we do not use adrenaline for minor indications. So adrenaline has specific indications. And what is that specific use of adrenaline? That is important to remember. Adrenaline is drug of choice for anaphylactic shock. Adrenaline is a drug of choice for anaphylactic shock. The first question is, why adrenaline is a drug of choice? Why noradrenaline is not the drug of choice? So first of all, we'll see this table. We know in anaphylactic shock, the word is shock. Shock means BP is low. So we want to increase BP. So just look at the table and tell me which drug is better to increase BP, adrenaline or noradrenaline. If we see, adrenaline increase systolic BP, but negligible effect on diastolic BP. On the other hand, noradrenaline increase both systolic as well as diastolic BP. So which should be better to increase BP? Obviously, it should be noradrenaline. But why noradrenaline is a drug of choice? Why adrenaline is not the drug of choice in anaphylactic shock? Although for increasing the BP, noradrenaline should be better. Why adrenaline? Reason is, before the shock also something is written. It must have some meaning. What is the meaning of anaphylaxis? Anaphylaxis manifests as severe bronchoconstriction. So in the anaphylactic shock, the patient has two life-threatening problems. One, BP is very low, and second, person is not able to respire. So if we increase the BP but person is not able to respire, the person will die. So we have to do bronchodilation also. And do you know what is the difference between adrenaline and noradrenaline? Remember, not all noradrenaline do not act on beta 2. So when it do not act on beta 2, it cannot cause bronchodilation. But adrenaline A for all. So that means adrenaline can stimulate beta 2, which can cause bronchodilation, and that can reverse anaphylaxis also. Okay, so adrenaline is a drug of choice because it can increase BP as well as cause bronchodilation. Both can be treated, so it can save the life of a person. That's why it is a drug of choice. Okay, noradrenaline will increase BP but cannot cause bronchodilation. So this is number one. Second question asked is, by which route you will give adrenaline for anaphylactic shock? Which is the route of choice? Very good. The answer is not IV. The route of choice is intramuscular. Intramuscular is the preferred route. And if it is not in the option, then mark subcutaneously. Do not mark IV. Remember, IV adrenaline is highly arrhythmogenic. It will increase the BP, but the person can die from arrhythmia. So we will not take chance. We will not give IV. We will give intramuscular or subcutaneous. Now, third question is, what is the concentration of adrenaline used for anaphylactic shock? The concentration of adrenaline used is 1:1000. Now the question is, what is the meaning of 1:1000? What is 1? What is 1000? So whenever we write any concentration in this manner, the first is always a drug. So in this case, it is adrenaline. And second is always the solution, total amount of solution. Okay? So means 1 part of adrenaline is dissolved in 1000 part of solution. So if we have 1000 part of solution, out of that 1 part will be adrenaline. Now a question is, what do you mean by part here? What is part? What is 1 here? Whether 1 is milligram or it is gram or it is kilogram, what is 1? Okay? So by normal nomenclature, whenever we write any concentration like 1:100, 1:1000, 1:5000, the first is always a drug, and that is always in grams. So that means 1 gram. And second part, 1000, what is 1000? That is in ml. So solution is in ml. So 1:1000 means if we give 1000 ml of this solution, you will get 1 gram of adrenaline. And we know 1 gram contains 1000 milligram. So that means 1:1000 means 1000 milligram adrenaline is present in 1000 ml of solution, or we can safely say 1 milligram is present in 1 ml. So 1:1000 means 1 milligram per ml of solution. If you give 1 ml solution, you are giving 1 ml adrenaline. Okay, so that is meaning of 1:1000. Okay, and in the emergency tray, In every hospital there is emergency tray. So adrenaline is already prepared as 1:1000, or we can say 1 milligram per ml. Already the vial contains that. So whenever the person comes in emergency, we will break the vial, load and inject. Clear? So important thing is we will not further dilute. It is already 1:1000. So many times what we say is adrenaline is given undiluted in anaphylactic shock. When we say undiluted, does not mean that we will give powder to it. Undiluted means it is already in solution, but whatever solution is present in the vial in the emergency tray, you give that directly. No need to dilute that. Okay. So that is important thing. Concentration is 1:1000. Okay. Now another important thing to remember, effect of adrenaline is concentration dependent. Okay? Like if we want to give 0.5 milligram, the dose is usually, what will be the dose of this solution? It will be 0.5 ml of 1:1000. That is important. But 0.5 milligram you can make by other methods also. Like if you make a solution which is 1:10,000, and if you give 5 ml of that, it will also be equal, because we have diluted 10 times and given 10 times high dose. Or you can also say 0.05 ml of 1:100. So 10 times concentrated solution, but 10 times lower dose. So all of them will make 0.5 milligram. But the right answer will be 0.5 ml of 1:1000, because the concentration is more important. In the exam, even if they write instead of 0.5, 1 milligram, or they write, 1 ml, or they write 0.7 ml, that can be the answer. But if they write 1:10,000 or 1:100, do not mark that. Okay. So concentration is important, dose is not that important. So adrenaline in anaphylactic shock, it is given as 0.5 ml of 1:1000 solution. Okay. Now patient has anaphylactic shock, and we have given 0.5 ml of 1:1000 solution by intramuscular route of adrenaline. Okay. 99% of the patient will get all right. The anaphylactic shock will be recovered, reversed, everything will become all right. But suppose there is 1% person who do not respond. So we have given 0.5 ml of 1:1000 by intramuscular route. The person is not responding, BP is not increasing. So what will you do? If the BP do not increase, what will you do? What will you do? Suppose in the first attempt you are not able to clear your exam. So what do you do? We repeat. So same thing here. So if the first dose fail, repeat. What to repeat? Again same. That means same drug, adrenaline, same route, intramuscular, same dose, 1:1000, 0.5 ml. So same thing, exact same we will repeat. But the question is when to repeat. So it should be repeated as early as possible. Remember, we do not have time. It is an emergency. Person will die. So maximum limit is 10 minutes. So we have to repeat within 10 minutes. In that 10 minutes, we are trying to make the diagnosis whether it is something else, because anaphylactic shock should have been improved with adrenaline. If it is not improving, there may be something else. So we'll try to find out some other cause. If we are not able to find out, repeat adrenaline. Okay. Same drug, same dose, same route. Everything same. Now suppose even this dose fail. Rest of the patients, around 99% of the rest of the patient will respond to second dose. Okay? Now if they do not respond to second dose also, what we will do? So usually if a person do not recover with second dose also, person will not recover with third also. Okay? So in this desperate circumstances, because we have already given adrenaline 2 times, still the BP is not increasing, the person may die. Very high chance the person will die. So in this desperate thing, we will give intravenous adrenaline. So intravenous adrenaline is given if the BP do not increase with the second dose also on intramuscular. But if we give 1:1000 by IV route, person will 100% die, because this is too high dose to be given IV. So important is whenever we give IV, we will dilute it 10 times. So IV dose is 1:10,000 ml. Okay? Intravenous is 1:10,000 ml, 10,000 concentration. Or we can say when we give IV, we will give it diluted. We will dilute it 10 times. So what we will do, from the emergency vial, we will take 1 ml and 9 ml of normal saline we will mix. So that will make us 1:10,000. So remember 5 points about adrenaline and anaphylactic shock. Number 1, drug of choice for anaphylactic shock, adrenaline. Number 2, route of choice, intramuscular. Number 3, concentration of choice 1:1000. Number 4, if first dose fail, repeat, same dose, same route. And number 5, if second dose also fail, then give intravenous but diluted, 1:10,000. Okay, so that is about adrenaline and anaphylactic shock. Now coming to second use of adrenaline, it is cardiac arrest. Adrenaline is used for cardiac arrest also. My first question is, what do you mean by cardiac arrest? Now there are certain terms which are very similar, so you should know about them. Cardiac arrest is one thing, then cardiac attack or heart attack. Heart attack is second thing. Third, heart failure is third thing. Heart failure. And fourth, heart block is next thing. So you should know these four have similar names, but they are totally different diseases. So one by one we'll discuss what the meaning. First of all, what do you mean by heart block? Heart block means there is conduction block. Conduction cannot go from atrium to ventricle. So heart block, the word uses AV block. Okay. Then what do you mean by heart failure? Heart failure means heart is not pumping effectively, contractility is reduced. So congestive heart failure, there is decreased contractility, heart is not pumping effectively. Then heart attack means there is myocardial infarction, there is less blood supply to heart, so heart is dying because of less blood. Okay, now what is cardiac arrest? Arrest means heart has totally stopped, heart is not beating at all. There is no heart rate, no pulse. Heart is not beating at all. That is heart arrest, cardiac arrest. Now, out of the four, which is the most serious? Obviously, cardiac arrest. Heart is not pumping at all. Heart is totally stopped. Person is almost dead. So, what will be the symptom of cardiac arrest? So, symptom obviously will be person will be unresponsive. Person is unconscious. Person is not responding to commands, obviously. When the heart is not pumping, no blood is going to brain, so person is not responding. Second, there will be no pulse because heart is not pumping, heart is present like that, no blood is getting pumped, so there will be no pulse, even carotid pulse cannot be felt. There will be no pulse, there will be no blood pressure because the heart is not pumping, BP is blood is staying there, so no pressure. So when you are not able to measure any blood pressure, not able to feel any pulse, the person is almost dead. So it is very serious condition, person is almost dead. So what we will do? First of all, we will start CPR, cardiopulmonary resuscitation. So we will do CPR. What we will do in CPR? Three things: CAB. C means chest compressions. Chest compressions. A is airway patency. And B is breathing. So first we will do, if a person is unconscious, person is having no pulse, no BP, we will start put our hands and press the chest. So what is the basic concept of pressing the chest is, heart is not pumping. So we need to manually squeeze the heart so that the blood can go out. So what we will do, the heart is present between the two bones, ribs in front, vertebra behind. So we will press the ribs, and when we press strongly, so heart will be pressed against vertebra. So that will squeeze the blood out of the heart. Clear? So that is chest compression. So important thing is, for chest compression to be effective, it should be pressed enough. So chest should go around 2 inches down. Clear? So what they advise is the elbow should be straight, it should not be bent. So while giving CPR, elbow should be straight and we press strongly around 100-120 beats per minute. Clear? So with force, and then it should be recoiling, it should come back, press, recoil, press, recoil. So that is given for 100 to 120 minutes. So that is very important. Second thing is airway patency. The way should be open. So mostly when the person become unconscious, the tongue falls back and that close the glottis. So even if you are giving air, it is not going in the lungs. So what you need to do is to open the airway. So mostly we shift the neck, slightly tilt the neck so that the glottis opens. Okay. And third, we will give breathing. mouth to mouth breathing, which is rarely used nowadays, ambu bag or ventilator. So basically we have to give breathing. So chest compression, airway patency and breathing. So that is started. Now, have you done CPR or have you seen anyone doing CPR? CPR is very tiring job to do. Remember, you have to press with force, and that is 100 times in 1 minute. You have to apply force. So when you give CPR for 2, 3, 4 minutes, you will see that you are panting. So you are so much tired that you have just run marathon. So within 2, 3, 4 minutes, this condition will be there. So continuously you should change the people doing CPR, because if one person is doing, it will become ineffective in few minutes only, because person cannot sustain that. So we should keep on changing. Whenever one person tires, the second person should give. Okay? So one thing we do is CPR. Second thing, if CPR, even after CPR, the spontaneous pulse is not coming, then we can give adrenaline. Okay. So adrenaline is a drug used in cardiac arrest. Now here again the question is, by which route you will give adrenaline? By which route? Yes, it is IV now. This is a serious condition. We are not worrying about arrhythmia. We are worrying about heart. Heart is not working at all. Even if it do arrhythmia, it is good. So we give intravenous adrenaline. Okay. And the dose is 1:10,000. We already discussed. By IV route, the concentration is 1:10,000. Okay. So we will give intravenous adrenaline 1:10,000. The first question is, after giving IV adrenaline, in how much time the heart will start pumping? So if we observe the person, how much time will be taken? Very good. If you observe the person will never respond. The reason is, you have given IV adrenaline, heart is not pumping, so it will remain here only. And if it do not reach the heart, how will heart pump? Okay. So the important thing is, after giving IV adrenaline, start CPR again. Do not stop CPR, because if we pump the heart only, then it will come to blood. Okay. So important thing is, do not stop CPR. Start immediately. Okay. Now second thing is, suppose we are not able to give IV. This happens very common. In the internship, you have to take the blood sample of the person from the veins. Okay? And most of the times, even in a healthy, conscious person, we are not able to find the vein. This is almost dead person. The veins may have collapsed, and many times it becomes very difficult to find the vein. And if we are not able to find the vein, so we cannot give IV. So if we are not able to give IV, then by which route you will give adrenaline? What is the next preferred route? It is intraosseous. Intraosseous in the bone. Remember, the venous plexus around the long bones is patent even in cardiac arrest. So if we inject adrenaline in the tibia, clear? So we will take a special needle comes. So we will inject adrenaline through that needle into the tibia, so it can be absorbed from the veins around there. So that is intraosseous. Okay? Now suppose we are not able to find the vein, we cannot give IV. Then we do not have the needle to inject into the tibia, we cannot give intraosseous also. Then by which route you will give? Yes, now we will intubate the patient, and after intubating we will put in the endotracheal tube. So the third preferred route is endotracheal. So in this sequence we will decide the routes. Preferred is IV. If not available, cannot give, given intraosseous, cannot be given endotracheal. Now when will you use intracardiac adrenaline? What is the indication of intracardiac adrenaline? Intracardiac adrenaline is only given at one place. What is that? That is in Hindi movies. Remember, intracardiac adrenaline has been banned long ago, around 20 years back, 2005 it has been banned. There is no indication of intracardiac adrenaline now. Do not answer intracardiac. It is not given at all. Okay. So that is about the adrenaline and cardiac arrest. Okay. Then third, adrenaline is commonly added to the local anesthetic solutions. Okay. So we will discuss the details about this in the anesthesia later on, but here just remember, adrenaline cause vasoconstriction. So local anesthetic will stay there for longer period. So adrenaline is added to make local anesthetic long acting. If we add adrenaline, it will remain for longer period. And second, because it is acting at that place only, not going to other place, so it will decrease the systemic side effects of local anesthetic. Systemic side effects will be lesser. And lastly, what concentration is given with local anesthetic? It is highly diluted, 1:1 lakh to 1:2 lakh. So highly diluted solution is given with the local anesthetic. So if we quickly revise the dilutions of adrenaline, 1:1000 is given by intramuscular route for anaphylactic shock. 1:10,000 is given by IV route for cardiac arrest and for unresponsive patients of anaphylactic shock, and 1:1 lakh it is given for with local anesthetic to prolong the duration of action. Okay, so these are the important uses of adrenaline. Okay, now we can move to the last but very important phenomenon, which is known as vasomotor reversal of Dale. Vasomotor reversal of Dale. Now, to understand this phenomenon, first of all, we need to know one important thing. Adrenaline act on which receptors? We remembered A for all. So that means alpha 1, alpha 2, beta 1, beta 2. And which receptor are present on the blood vessels? We know alpha 1, which cause vasoconstriction, and beta 2, which cause vasodilation. This we have already discussed. Now, what is the special thing to remember? The sensitivity of alpha 1 and beta 2 receptor is different. To understand, you just remember that beta 2 receptors are more sensitive for adrenaline, but alpha 1 are more strong. Now, what do we mean is, even if we give low dose of adrenaline, it can stimulate beta 2 because they are sensitive. At low dose, we cannot stimulate alpha 1. Alpha 1 require higher dose because they are not that sensitive. But if we give high dose, both can be stimulated, alpha 1 as well as beta 2, both can be stimulated. But when high dose is given and both are stimulated, effect of alpha 1 will be predominant. The effect is stronger. Okay? So beta 2 can be stimulated at low dose, but when both are stimulated, effect will be of alpha 1. Okay? Now, to make it more clear, we will make it mathematical. Like, suppose for stimulation of beta 2 receptor, only 10 molecules of adrenaline are enough. At 10 molecules, alpha 1 cannot be stimulated. For stimulating alpha 1, suppose we require 50 molecules. So at less than 50, only beta 2 will be stimulated, but when we give 50 or more, it stimulates both beta 2 and alpha 1. Okay? Now, suppose we give 100 molecules of adrenaline IV. We give 100 molecules of adrenaline by intravenous route. Which receptor will be stimulated? Both alpha 1 and beta 2 both will be stimulated. Suppose this is the normal blood pressure. This is the normal blood pressure. We give 100 molecules of adrenaline here. So what will you expect on BP? Will it increase or will it decrease? Obviously it will increase, because although both are stimulated, but effect of alpha 1 will be predominant, and alpha 1 we know is causing vasoconstriction. Vasoconstriction will increase BP. So on giving 100 molecule, BP increases. Suppose this BP is 120. After giving adrenaline, it become 180. And why it is 180? Because alpha 1 is more powerful than beta 2. Both the receptors are stimulated, but alpha 1 effect is more. But we know that after some time, adrenaline of the blood will be metabolized. So from 100, it will become 90, 80, 70, 60. So when it start decreasing, the effect will also start decreasing. So the BP which has gone to 180, it will start returning toward 120. Now the question is, will the BP stop here? The answer is no. Because when it start getting metabolized, and whenever it become less than 50, so from 100 it become 90, 80, 70, 60, 50, now it become 49. Now whenever it become less than 50, what will happen? Now there is no action on alpha, but beta 2 is still getting stimulated. So when 49 molecules of beta 2 are stimulated, so that will produce vasodilation and decrease in BP. So this decrease is due to beta 2. So 49 molecules of beta 2 are getting stimulated, they will decrease BP. Okay. But even these 49 will be metabolized. So from 49 they become 40, 30, 20. So this will also start recovering. And when they are metabolized to less than 10, now even beta 2 cannot be stimulated, so it will become normal again. So when we give adrenaline high dose by IV route, it produces first increase in BP, then decrease in BP. So this is known as biphasic response or we can say biphasic effect on blood pressure. Biphasic, the name tells, first BP increase, then BP decrease. So adrenaline first increase BP, then decrease BP. This is the normal action of high dose of adrenaline. Okay. Now, whenever we give adrenaline, we are expecting that first BP will increase and then it will decrease. Okay. Now we give same high dose of adrenaline, 100 molecules, but we have already given this person alpha blocker. If we already give alpha blocker and then give high dose adrenaline, what will happen? What will happen? First we give alpha blocker. So remember, we have given 100 molecules, but we have already blocked alpha. So all 100 will stimulate beta 2 only. They cannot act on alpha because that is already blocked. And when beta is stimulated, what will happen? Vasodilation. And when vasodilation occurs, what will happen? BP decrease. So here, if we give adrenaline after giving alpha blocker, what will happen is BP, instead of increasing, will directly start decreasing. Okay. Now, will it decrease to this much extent only? No, because this was caused by 49 molecules of beta 2. But when all 100 are acting on beta 2, this will be much less. Suppose it was becoming 80 earlier, now it will become 20. So what we note is, if adrenaline is given with alpha blocker, or alpha blocker is already given, then adrenaline is given, what will happen is, number one, this biphasic response is not noted. Increase is not seen, only fall occurs. So what we were expecting, that BP will increase first, but it decreased. Number thing is, only decrease, increase is not happening. And second thing, this decrease is also exaggerated. Normally the decrease should be till 80, but here it will become till 20. So significant decrease in BP will occur. This is known as vasomotor reversal of Dale. The name tells vasomotor means blood vessel, muscle of blood vessel. Reversal, action is reversed. We were expecting vasoconstriction, BP will increase, but has happened, BP has reduced of Dale. So first of all, it was noted by scientist Henry Dale. So it is called as vasomotor reversal of Dale. And this was noted, particularly alpha blocker, where it was noted was with ergot alkaloids. Ergot alkaloids were the first drugs given with adrenaline when we noted that there is vasomotor reversal of Dale. Okay. So what is vasomotor reversal of Dale? What happens when we give alpha blocker and then we give adrenaline, instead of biphasic response, instead of first increasing BP, it directly start decrease in blood pressure, and that decrease is very significant. BP can become zero also. Very low BP comes. Significant happens, and decrease in BP happens, shock happens. Okay, that is called as vasomotor reversal of Dale. Now the question is, we discussed a little while earlier that adrenaline intravenous is very dangerous. If we give IV, it can cause arrhythmias. And now we are talking about, if we give IV adrenaline in high dose, what will happen? So why we will give IV adrenaline? We will never give. So then why we are talking about vasomotor reversal when we will never give IV adrenaline? The reason is, we do not give IV adrenaline, but it can come in the blood in high concentration. In which condition? In pheochromocytoma. Remember, there are two types of pheochromocytoma. Some people have noradrenaline producing pheochromocytoma. Some people have adrenaline producing pheochromocytoma. Now what will happen? This is the normal BP 120 of a person, and this person has noradrenaline producing pheochromocytoma. If noradrenaline is produced, it can stimulate alpha 1, alpha 2, beta 1. So by acting on alpha 1, it will increase the BP. So when noradrenaline producing tumor is there, by stimulating the alpha 1 receptor, the BP increases. Alpha 1 receptors are stimulated, BP increases. So BP has nearly become 180. Remember, there is no beta 2 action, but alpha 1 can cause vasoconstriction. Now if a person has adrenaline producing tumor, adrenaline can stimulate all, alpha 1, alpha 2, beta 1, beta 2. So if this is the normal BP, after adrenaline comes in the blood, the BP will again become 180. And this happens because alpha 1 is stimulated more than beta 2, because alpha 1 is powerful. So BP is still high. So both adrenaline producing as well as noradrenaline producing tumor, the patient present with hypertension, BP is very high. Okay. And we know that this high BP is because of stimulation of alpha 1. And the first logical thing that will come in our mind is block alpha 1, because alpha 1 is increasing, BP, block that. So what we do, we give alpha blocker. If we give alpha blocker to this person, it will block alpha 1, so the BP will become normal. Because alpha 1 was increasing BP, we have blocked alpha 1, BP become normal. But in this person, if we give alpha blocker, what will happen? BP will not become normal because we have blocked alpha 1, beta 2 still works. So the BP will fall. Vasomotor reversal happens. So when BP falls, the person can go into severe shock. Remember, from 180, the BP become 20. So the person go into severe shock and the person may be very difficult to revive, and many times the person dies. Okay. So this is the clinical importance, that if a person is having adrenaline producing pheochromocytoma, only alpha blocker may kill a person because of vasomotor reversal of Dale. Okay. So quickly revising about pheochromocytoma. You see two type of pheochromocytoma: adrenaline producing, noradrenaline producing. So in case of adrenaline producing pheochromocytoma, we should never give only alpha blocker, because that may kill a person because of vasomotor reversal of Dale. So in noradrenaline producing tumor, we can give only alpha blockers because vasomotor reversal will not happen. Okay. Now, what is the solution? That if the vasomotor reversal happens, we do not want the BP to reduce. So what we can do? We can block beta. Remember, beta 2 was causing vasodilation. If we block beta, vasomotor reversal will not happen. So what is the solution in adrenaline producing tumor? Is give alpha plus beta blocker, so that vasomotor reversal do not happen. Clear? Whereas this is safe here also. If we block beta, we are not going to do any harm. So alpha plus beta blocker can be given in both of them. Whereas in adrenaline producing, we have to give noradrenaline. Even if we give only alpha blocker, it's okay. Okay. But number 3 thing you need to remember is beta blocker alone. They should never be given here. They should never be given here. Only beta blocker should not be given, because if we block beta 2, little bit vasodilation which is causing, even that stop. So BP will increase further. From 180, it will become 200, 220. That can lead to hypertensive emergency. So beta blocker alone is contraindicated in any pheochromocytoma. So it is always better to give alpha plus beta blocker. But in noradrenaline producing, you can give only alpha blocker also, but alpha blocker alone is contraindicated in adrenaline producing pheochromocytoma because of development of vasomotor reversal of Dale. Okay. So these are the important points regarding the catecholamines. Now we will move to the second group of directly acting drugs, which are called non-catecholamines. And the non-catecholamines we discussed, they may be effective orally because they are not broken down by COMT in the GIT. Okay. Now we will discuss these drugs based on the receptors on which they work. Okay. So we'll start with the drugs working on alpha 1 receptors. The drug stimulating alpha 1 receptors 1 in the eye. So we have a drug called as phenylephrine. Phenylephrine, it is an alpha 1 agonist in the eye. So when we use it as eye drops, what it will do in the eye? Yes, it will cause mydriasis, dilatation of pupil. And mydriasis is required for which condition of eye? Yes, to fundoscopy. So to examine the retina, we can use phenylephrine. But important thing is, which other mydriatic drug we discussed earlier in the videos? Yes, we discussed anticholinergic drugs like atropine, hometropine. So what is the difference between phenylephrine and atropine in the eye? Both are causing mydriasis. So what is the difference? It causes only mydriasis, phenylephrine. It do not cause cycloplegia. Whereas anticholinergic drugs cause cycloplegia also. Remember, on the ciliary muscle, there is no sympathetic supply. There is only parasympathetic supply. So anticholinergic can cause cycloplegia, but adrenergic drugs will not cause cycloplegia. So remember, it causes mydriasis without cycloplegia. So that is the MCQ asked, which of the following drug cause mydriasis without cycloplegia? The answer is phenylephrine. Okay. Then we can use the drugs in the blood vessels for action on the blood vessels. The drugs like methoxamine, mephentermine, and midodrine. So these are the drugs. They are given for the action on the blood vessels. So what they will do? Alpha 1 in the blood vessel cause vasoconstriction. So they will cause vasoconstriction. The BP increases. So where we will use them? We will use them in treatment of shock. Which type of shock? With oliguria or without oliguria? Yes, without oliguria. With oliguria, we need to protect kidney, so we need to give dopamine. So they are used for shock without oliguria. Basically, they increase the blood pressure, so they are used in shock. And you can remember that from the name also. If you see, their names start with me and they contain mine. So they are me and mine. It is me. So they are always talking about themselves, me and mine, me and mine, me and mine. So they are type A personality, always anxious about themselves. So type A personality people usually have high BP. So they are also increasing BP. So me and mine drugs, type A personality, increase BP. So they increase BP. So they are used for shock. Okay. Then we have a drugs like xylometazoline. The drug name end with the zoline, oxymetazoline, and nafazoline. So these drugs, they are used as nasal drops, and they cause vasoconstriction in the nose. So they are used as nasal decongestants. Now what is important is they cause nasal vasoconstriction. Do you remember which other nasal decongestant we discussed earlier? Yes, we discussed drugs like ephedrine, pseudoephedrine. So what is the difference between ephedrine and xylometazoline then? Ephedrine was oral drug. Remember, it was present in cough syrups, and we do not instill cough syrup in the nose. We take them orally. Whereas these are drops, they are used locally. Okay, so they are local nasal decongestant, whereas ephedrine was systemic nasal decongestant. Okay. Now, it is not exactly known whether they stimulate alpha 1 receptor or they stimulate post-synaptic alpha 2 receptor. So some books say they stimulate alpha 1, some say they stimulate post-synaptic alpha 2, but basically they stimulate vasoconstriction. Remember, post-synaptic alpha 2 work like alpha. Now a patient was given xylometazoline. It caused nasal vasoconstriction, so the blocked nose opens. Okay, so the person is very happy. So we have given xylometazoline drops 2 times a day or 3 times a day. So person instill the drop and it causes vasoconstriction in the nose that opens the nose. So person is very happy. But after 10 minutes, what happens? When the effect subsides, now again vasoconstriction, vasodilation occur. So again nasal congestion occur, and usually this congestion is more than earlier. The nose is seemed to be blocked even more than earlier. So this side effect is known as after congestion. So after congestion means after the effect is over, congestion increase again. Clear? So usually it is more than earlier, rebound congestion occurs. Okay. So we had given the drug twice a day, thrice a day, but the person is very smart, we know. So person thought that 10 minutes earlier, 15 minutes earlier, I had instilled the drop and my nose opened. So I will instill again. So person again instill the drop, again vasoconstriction occur, again the nose opens. But after 10 minutes, same problem occurs, again congestion. Person instill another drop. So person keep on instilling the drop again and again and again and again. So what will happen? Now there is constant vasoconstriction in the nose. When there is constant vasoconstriction, even normal blood supply will be compromised. So that can lead to atrophy of the mucosa there. Clear? So that condition is known as atrophic rhinitis. Because of repeated uses of nasal decongestant, there will be atrophy, which is known as atrophic rhinitis. Because it is caused by medication, so this is also known as rhinitis medicamentosa. This is the MCQ asked, which of the following drug if we use repeatedly can cause rhinitis medicamentosa? The answer will be zolines, xylometazoline, oxymetazoline like drugs. Okay, so these are the important drugs which act on alpha 1 receptors. Okay? Then moving to alpha 2 receptor. If you remember, alpha 2 receptor act like brake. They put the brake to the sympathetic system. So if we stimulate alpha 2, we are putting the brakes. And the drug stimulating alpha 2, the main drugs are clonidine and methyl dopa. They stimulate alpha 2 receptor. They put the brake on the sympathetic system. So that will decrease blood pressure. So they are used in treatment of hypertension. So clonidine and methyl dopa like drugs, they are used for treatment of hypertension. We will discuss them again in cardiovascular system. Okay. So that is important about the alpha receptors, alpha 1 and alpha 2. Now regarding the beta receptors, we do not have any non-catecholamine that stimulate beta 1. All the drugs which stimulate beta 1, we have already discussed in the catecholamine group. Okay? So now non-catecholamine are there which stimulate beta 2, not beta 1. Okay, so beta 2 stimulating non-catecholamines will discuss under two headings. One which are given by inhalational route. Inhalational route. These drugs are salbutamol, terbutalin, salmeterol, and formoterol. These are given by inhalational route, and we know when we give inhalationally they will go to lungs. So what will they do? They cause bronchodilation, and bronchodilation is required for, yes, asthma and COPD. So they are used in treatment of asthma and COPD. They are bronchodilators. They are given by inhalational route. Now all these drugs, they have some side effects, and that side effects you can remember as 3Ts. 3Ts. What are the side effects? That is tachycardia, tremors, and T wave changes in ECG. Now one by one we will discuss. First of all, tremors. We know tremor occur due to which receptor? Beta 2 stimulation, and they are stimulating beta 2, so they can cause tremors. So tremors in fact are the most common side effect of these drugs. Most common side effect of beta 2 agonist is tremors. Okay. Then second is tachycardia. Tachycardia is due to which receptor? Beta 1, but they are stimulating beta 2. So how they will cause tachycardia? So normally they do not cause tachycardia. Okay. At therapeutic doses, they do not cause tachycardia. So, but whenever we increase the dose, we give high dose, the selectivity is always lost. Although they are stimulating beta 2 and beta 1 is negligibly stimulated, but when we give high dose, even significant stimulation of beta 1 also occur. Clear? So at high doses, they cause tachycardia. So tachycardia is seen only in high doses. Now, third important thing is the potassium which is present in the blood. Remember, the potassium which is present in the blood, it is afraid of two things. Potassium is afraid of two things. What are those two things? One is insulin, and second is beta 2 agonist. So if we give any drug which stimulate beta 2, or if we give insulin, potassium is afraid of them. So potassium which is present in the blood will go inside the cells. So when the potassium go inside the cells, there will be less potassium in the blood. So that can lead to hypokalemia. So these drugs, they can cause hypokalemia as a side effect. Hypokalemia is the side effect of these drugs that result in T wave changes in ECG. So that was just the mnemonic. The important thing you need to remember is hypokalemia. So beta 2 agonist can cause hypokalemia, and in fact this side effect can be used for treatment of hyperkalemia. So whenever there is hyperkalemia, we can give salbutamol inhalation. They can treat hyperkalemia. Okay, so these are the three important side effects, but be very careful. In exam they ask the question, which of the following is not a side effect of beta 2 agonist, and answer to that question is almost always hypoglycemia. Remember, what is the action of beta 2 in the liver? It increase blood sugar. So beta 2 agonists will never cause hypoglycemia. They can increase sugar, but they will never cause hypoglycemia. So hypoglycemia is not seen with these drugs. Okay, so that is about the salbutamol like drugs. Now there is second group of beta 2 agonists which are ritodrin and isoxsuprine. These are also beta 2 agonists, but we are using them mainly for their action on the uterus. Mainly for their action on the uterus. And what is the effect of beta 2 agonist on the uterus? Yes, it will relax the uterus, and a relaxation of uterus is called as tocolytic effect. So these drugs have tocolytic action. And which condition you will want to relax the uterus? Yes, we discussed earlier also in case of preterm labor. So these drugs are used in preterm labor. So labor pains have started at 7 months and we do not want delivery now. So we give ritodrin like drugs. They will postpone the delivery. They will relax the uterus. So what is their use? In the preterm labor, when we use them, they delay labor. So we are using them to delay the labor so that the labor pain do not come now. Now read the question carefully. They ask the question, which of the following is not a use of ritodrin? or which the following is use of retrodrin, something like that. So in the option they will write delayed labor. So read carefully. They do not, they are used to delay labor. In delayed labor, they will be rather contraindicated. Delayed labor means already 9 weeks have passed, 9 months have passed. Already pregnancy is beyond 36 weeks, still no labor pains. So when there is no labor pains, we want to induce labor. So delayed labor, they are not used. They are used to delay labor so that the labor pains come later on. Okay. Now, like all beta 2 agonists, they cause 3 T's as a side effect. Tachycardia, tremor, and hypokalemia can occur. In addition, they can also cause pulmonary edema. They can cause pulmonary edema, another side effect of retrodrin-like drugs. Okay. Then lastly, we have beta 3 agonists, drugs acting on beta 3. And we already discussed beta 3 relax the bladder. So we use the drugs in overactive bladder. So beta 3 agonists are used in overactive bladder, and one drug we discussed from the name we have made the mnemonic, that is called mirabegron. Remember mirabegron, and a new drug in this group is vibegron. So mirabegron or vibegron, they are beta 3 agonists. They are used in overactive bladder. Okay, these are the important points regarding the adrenergic drugs. We have discussed directly and indirectly acting all the drugs. Okay, so a quick recap what we have studied in this chapter. We have studied a lot in this chapter, and this is important. Okay, so first of all, you should be thoroughly knowing about different receptors of sympathetic system where alpha 1, alpha 2, beta 1, beta 2 are present. All the details you should remember, but only that much which I have taught you. Clear? Note more than that. In the books, you will find much more extra information not required, but this is important. Okay? Then second, we divided the drugs, adrenergic drugs, into two types: indirectly acting and directly acting. Indirectly acting further of two types: drugs acting by inhibiting the reuptake and drugs acting by displacement. So most important among them you need to remember is about cocaine. Lot of questions are asked on cocaine addiction, cocaine as anesthetic. So cocaine is very important. Then directly acting we divided into catecholamines and non-catecholamines. Catecholamines in particular, you should remember about actions of adrenaline, noradrenaline, and dopamine. The table which we have made, the graphs which are asked from that, plus you should remember the uses of these drugs. Whereas in the non-catecholamine group, we have divided the drugs according to the receptors, alpha, beta receptors. So lot of questions are asked from that, and the most important thing which is remaining is vasomotor reversal of Dale. Several questions are asked from this. Okay? So I expect you to minimum remember these things. Okay, so we can see some of the questions. All of the following are side effects of retrodrin except retrodrin we just discussed is beta 2 agonist. So which is not a side effect of beta 2 agonist? Question asked is hypoglycemia. This is the answer. First is the answer we discussed. Beta 2 agonist can cause increase in sugar, but they will never cause hypoglycemia. Tachycardia can be seen by beta 2, vasodilation occur, hypotension can occur, pulmonary edema can be seen with retrodrin. So answer is hypoglycemia. Okay. Which of the following is action of dopamine at low doses? So first of all, what is the meaning of low dose? It is less than 2 microgram per kg body weight per minute. Okay. So at low dose, which receptor it is stimulating? Yes, D1. Remember D1, beta 1, alpha 1 in this sequence. So at low dose only D1 will be stimulated, and D1 was causing mainly renal vasodilation. So if we see increased renal blood flow, yes, this can happen. Causes vasoconstriction, wrong, it require alpha 1 which is high dose. Positive chronotropic require intermediate dose, and causes hypotension is wrong, it do not cause hypotension, it causes hypertension, increase in BP. A lady was stung by many bees. She developed breathing difficulty and hypotension. So respiratory problem, hypotension, so it is suggestive of anaphylactic shock. Drug of choice, answer is easy, adrenaline. We all know adrenaline is drug of choice for anaphylactic shock. Okay. A drug addict patient presented with agitation and ulceration on the skin. Patient has severe itching and scratch marks. On examination, there is presence of tachycardia, mydriasis, and hypertension, likely substance. So all these fit into cocaine. Remember, two important things about cocaine we discussed. One, cocaine bugs, and second, sympathetic effect we discussed. So cocaine bugs, they are telling from the ulceration, from the scratch marks of the skin. And sympathetic symptoms, tachycardia, hypertension, mydriasis, all the sympathetic symptoms. Plus in the CNS, it can cause agitation. The answer is cocaine. Okay. Which dose of dopamine act preferably on beta 1? Remember, intermediate dose D1, beta 1, alpha 1, and intermediate is 2 to 10. So remember, this is not the exact dose which they have written. Ideally, they should write 2 to 10 microgram written per kg body weight per minute. So that is the right dose. Not only microgram, it is microgram per kg body weight per minute. Okay. Then which of the following drug act on beta 2? Which drug act on beta 2? So we'll see one by one. Mirabegron act on mirabegron. It is acting on beta 3. Dopixamine. Remember, dopixamine contains dopa in the name, so it stimulates D1 receptors, but in addition, it stimulates beta 1 and beta 2 also. Phenol dopam is only dopa, so only D1 receptor. Now, dipivefrin is a pro-drug of epinephrine. Dipivefrin is a pro-drug of adrenaline. We'll discuss that in glaucoma. It's a pro-drug of adrenaline because it is acting on like adrenaline, so it has all alpha 1, alpha 2, beta 1, beta 2. So now we will see they are asking which act on beta 2, and we can see that beta 2 is present here and beta 2 is present here. So answer will be dopixamine and dipivefrin. So it is 2 and 4. Okay. So these are some of the important questions. So we completed a very, very important topic, which is adrenergic drugs. Okay. Now my take home message is it's hard to beat a person who never gives up. Remember, giving up should never be an option. You should always keep on trying, always keep on trying. Giving up should never be an option. Okay. Thank you very much.